Oh, you can come up now. Okay, why don't we go ahead and get started. Good morning. Welcome to Houston. I'm Chris Wood. I'm a member of the Department of Urology here at MD Anderson. Just a few housekeeping issues. If you do have any housekeeping issues, please see the conference staff members at the registration desk, and they'll be happy to assist you. Just to let you know, our conference today will be producing a live stream YouTube broadcast as well as a videotape for webcast to be posted for the Kidney Cancer Association website at a later date. As we are streaming live today, during our question and discussion sessions, I'd like to ask you to not identify yourselves or any patients you may reference during a question presented to our panel members. There will be no facial recognition caught by our cameras of the audience, only audio. And please be certain you fill out the authorization for the use and disclosure of protected health information form and return to my Secretary Carol at the registration desk. Please silence all electronic devices during the duration of the day. If you need to place any phone calls, please step outside the room to avoid taping interruptions. We have scheduled 2 breaks, one at 10:30, one at 2:10, and lunch will also be provided at 12 noon. Seating for lunch is available in rooms 1, 2, and 3 and on the opposite side of these conference rooms. And for those of you who want to attend, we have scheduled a luncheon meeting with the Department of Social Work. These are 2 separate closed session meetings, one for patients and one for caregivers. The caregiver meeting is in the telemedicine room and the patient meeting is in room 4. Staff members from the Department of Social Work will meet with both groups to facilitate an open discussion session. And then finally, we'd like to thank our conference supporters, both Pfizer and Genentech. So, welcome again to Houston. We're going to try a very different format this year. We've done this, I don't know, maybe the last 5 years, I think, here in Houston. And sometimes I look out at the audience and I see sort of this glazed look in your eye. And not sure whether you're taking it all in, whether it's valuable to you. So we're going to try a totally different format, and we do need your feedback. If you like this format, then let us know. If you hate this format, then also let us know that, and we can switch back or maybe have a mixture of the two. But this is what we in the health profession call a tumor board. And basically, this is how we practice medicine. We take difficult cases that present to us and present them to our colleagues and get their opinions about how best to manage it. And we pick these cases so that hopefully we can cover what we would normally cover during the didactic sessions. We have a very esteemed expert panel. We have Jose Karam, who's on the faculty at MD Anderson with us. Roberto Pili is visiting us. He's a medical oncologist. We have Scott Delacroix, a urologist. Michael Harrison, another medical oncologist. Brian Chapin, urologist here at MD Anderson. Cameron Arar, who's an interventional radiologist who is an expert in ablation. Serena Mateen, another urologist. Nazar Tanir, and myself. So if I could first have the panel come up for the localized and locally advanced disease. That's Jose, Nazar, Michael, Serena, Brian, Scott, and Cameron. And hopefully we have enough chairs. So during the course of the case presentations, if you have questions, please don't hesitate to get up, step to the mic, and I'll acknowledge you and you can ask your question. If you have a question about what somebody says or things are not clear, please let us know. In all fairness and against my wishes, these guys have already seen the cases, so they've already probably prepared some of their answers, but I'll do my best to try and confuse them the best I can. All right, so let's start with our first case. This is a 52-year-old white female who presented with a history of metastatic carcinoid, and during the course of her evaluation for her carcinoid was noted to have an incidental renal mass. She also has a history of Hodgkin's lymphoma, cervical CIS, thyroid cancer, diabetes, and hypertension. She's had numerous surgeries in the past. She's had a splenectomy, a partial liver resection, partial stomach resection. Her gallbladder has been removed, her uterus has been removed, as well as her thyroid. She has an excellent performance status, meaning she has no side effects from her disease. Her labs are all within normal limits, and her CT scan of the chest is negative, meaning no evidence of any metastases to the chest. Here's her scan, and you can see here in her left kidney, medially, she has a solid mass present that enhances with the administration of contrast. There's two views here. And I guess I'm going to throw this out to first Dr. Mateen. How would you approach this patient? What would you offer this patient, and why?
So I think the first thing that everybody thinks of is whether this is the carcinoid that's spread to the kidney, right? I mean, she's got already a cancer. And what we've learned over the years is that, first of all, carcinoid doesn't go to the kidney very often. And secondly, metastatic lesions to the kidney tend to have a somewhat distinct appearance in that they're not actually very well vascularized for whatever reason. So anyway, my first instinct looking at this is that it's probably not this carcinoid, depending on what the status of that was. That, you know, if it's sort of widely metastatic, then I would reconsider. But if it looks like it's one of these smoldering, for those of you that don't know, carcinoid has a very long history. Patients can live with it for a very long time. It's still, you know, not a great disease. But anyway, my point with this is I think depending on what the status of her carcinoid was and how active it was at the time, you know, continuing to observe it would be reasonable given its size. And I can go into that more if you wanted to.
All right, so you're recommending just observation. You wouldn't recommend any intervention.
Yeah, and I think I just need to hear a little bit more about what's going on with her carcinoid, what kind of interventions she's had, and things like that.
You saw the surgery that she's had. Those are interventions. Currently, she has no evidence of disease aside from this renal mass.
Yeah, so, you know, in that setting, I think continued observation is reasonable, and the alternative is for her to have this treated and resected. And a part of it, you know, the patient has to be involved with the choice. To some degree.
She says, whatever you think, Dr. Mateen.
Yeah. No, listen, I think because carcinoid has such a long history, I think treatment would be what I would probably recommend.
And what would that treatment be?
Options would be a partial nephrectomy, either open or robotic, or doing ablative therapy. it's a little bit tricky for that, and maybe Cameron wants to comment on that.
What would you recommend, though?
What would I recommend?
Mm-hmm.
Sure, I would do a robotic partial.
You do a robotic partial.
Yeah.
Dr. Delacroix, what would you recommend for this patient and why?
I would do an open partial nephrectomy, especially given her history of multiple abdominal surgeries. I'd want to go through a flank incision and do a open robotic.
Yeah, I would think it would be very challenging to do anything laparoscopically after having stomach, liver, spleen, everything else resected.
That being, if you had to pin me down, I'd say open partial, but active surveillance would also be reasonable.
Open partial. Okay, Cameron, what about ablation? Do you think this is something that could be ablated?
Yeah, so for those of you who don't know, thermal ablation can be done either in the operating room or in a radiology suite using an MRI or a CT scan. We look at a tumor, two things that are most important to consider. One is the size of the tumor. The other one is the location of the tumor. In this case, this tumor being less than 4 centimeters is a good candidate. The location, like Dr. Mateen said, is a little tricky. It's a little close to the hilum of the kidney where the connection to the ureter is, and excessive heat or excessive cooling of the tumor can damage the drainage of the kidney. So in this case, I think I would suggest that we can ablate this. We would take some measures to protect the kidney, in the inside of the kidney, the ureter, the UPJ, from excessive heating. Yeah, we can ablate this.
Would anyone consider a biopsy of this lesion? I noticed no one said biopsy. Would anyone do a biopsy?
Sorry.
You go first.
So yes, the concept of biopsy is a tricky one to discuss. As you know, before the days of ablation, and this dates back before 2000, really, the ablation has gained acceptance since 2000, 2001. But before the days of ablation, where all of these tumors were taken out surgically, nobody did biopsies. Still, even now, when a surgery is planned, we don't biopsy these tumors. 85, 90% of them are thought to be renal cell carcinoma, and they go to surgery. Some of them do turn out to be benign. In this particular case, with prior history, I think it's reasonable to do a biopsy. The question becomes whether you do the biopsy a week before so that you know exactly what you're treating, or you go in with the intent to treat the tumor, but you take a biopsy at the time of the treatment for follow-up purposes to know what it was that was treated. So yes, I would definitely incorporate it into the treatment, whether you do it ahead of time or at the time of the procedure. That varies.
And Cameron, I'd like you to comment on one thing. Many patients bring up the concept of, when you biopsy a tumor, that it could potentially pull cells out of the tumor and potentially seed the cancer. And also, could you speak to maybe the MD Anderson experience with regards to the accuracy of biopsy? How often do you actually get a result that's meaningful?
So yes, the risk of tract seeding, as Dr. Wood mentions, putting a needle inside a tumor and taking some of the tumor out, does it increase the risk of seeding the tract? Traditionally, when I went to medical school, people said, my professor taught me, never touch a kidney cancer. They all go to surgery. Don't put a needle in it. But that has changed drastically over the years. We have now learned that we don't see this. The entire concept of tract seeding for kidney biopsies based on 6 individual case reports that were reported in probably 70s. And since then, a lot of the research has been done on biopsies before surgery or before ablation or for medical therapy have shown that biopsy is very safe. The risk of tract seeding or seeding the area that we biopsy is less than 1%. And that's true for majority of tumors. Now, there are some questions about some sarcoma, some transitional cell carcinoma, and other tumors other than kidney cancer. But generally accepted in this day and age, the risk of tract seeding is less than 1%. Our experience has been very positive. It being a cancer center, biopsy is one of our most common procedure in interventional radiology. We're pretty good at it. We can get small tumors. We can get large tumors. We can get tumors that are partially or nearly completely dead, but they have a nodule, very small part of it that's alive, and we go after that, and we get that. And our results are pretty much 90% diagnostic, 95% diagnostic. Very rarely you will have false positive, almost never heard of. Occasionally you will have false negative, that is, there is cancer, but we didn't find it. That happens probably about 5% of the times.
Anyone else have any other comments? So this patient actually underwent ablation. Cameron, you probably did this ablation.
I did, yes.
Do you want to just sort of take us through the thinking behind this? I guess questions I have are, when do you decide to do cryoablation versus radiofrequency ablation? And how did you decide on this approach versus some other approach?
Sure. So a couple of things I need to explain first. There are two ways you can treat the tumors by means of thermal energy. You can either heat it to excessive temperatures, almost nearly boiling water temperature pretty much, and heat up an area what we call ablation zone, which engulfs not only the tumor, but a little bit of a normal kidney around it. So you get enough margin around the tumor that you're happy about, you didn't leave any tumor behind. That's one, it's called radiofrequency ablation. The other end of the spectrum is actually cooling the tumor to temperatures minus 180, 160 degrees centigrade, which creates a very cold ice ball, which essentially kills all the cells that are engulfed in that ice ball. Both technologies are available percutaneously, and both are effective. Now, every time you look at a tumor, you decide which technology would be more appropriate or which one you would feel more comfortable. There are some minor technical details that I don't want to bore you with, but in this particular case, we decided to do radiofrequency ablation, and in fact, we had our urology colleagues come to our suite and place a catheter up the ureter into the kidney where we could infuse cold water inside the kidney, where we're heating the tumor right next to it so that inside the kidney would be protected from the excessive heat. We normally place 1, 2, or 3 of these needle-like electrodes. Chris, if you want to highlight it with the mouse, they can see it. We place 1, 2, or 3 of those needle-like electrodes within the tumor, and we create an ablation zone that covers the entire tumor. This technology has been available since 2000. Nowadays, we think it's about 95% effective.
Okay, very good. All right, let's move on to another case. This is a 74-year-old who presented with abdominal pain. And again, a CAT scan that was obtained because of this abdominal pain demonstrated an incidental right renal mass, which is one of the most common presentations we're seeing nowadays. Past medical history is significant for hypertension, diabetes, and also inflammatory bowel disease. And the patient currently is taking steroids for it. Also history pulmonary fibrosis, and the patient is morbidly obese. She's had numerous back surgeries and currently gets around in a wheelchair. And you can see here in the right kidney, and again, for those of you that have not seen CAT scans before, basically this is like looking from the feet upwards. So this is the right, this is the left. Here's the liver, here's the gallbladder, here's the spine. This is the left kidney, this is the right kidney. You can see in the right kidney, there's a mass posteriorly present in the right kidney. So I'll throw this one to Dr. Karam. Dr. Karam, how would you manage this patient?
I would check with his internist first to see what his prognosis is from the pulmonary fibrosis standpoint. These could be either stable or it could be progressive disease. So if the patient is progressing with the pulmonary fibrosis, then active surveillance would be really the only realistic option to discuss with the patient or to recommend. Otherwise, we can offer other therapies such as ablation or surgery, but surgery would be the lowest on the recommendation list. So for this patient, I would choose or recommend active surveillance first. And if the patient would like active therapy or insists on active therapy, I think this is probably a good position for ablation therapy given the posterior location, although it is close to the hilum.
Let's just assume that her pulmonary fibrosis is stable on steroids. So you're recommending?
Ablation therapy.
So you're recommending ablation. Cameron, what do you think about ablating this thing?
I think, again, the size is reasonable. It's probably at the upper limit of what I consider ideal. The location is a little tricky, kind of like the last case. Would be on a scale of 1 to 10, and degree of difficulty would be a 7 or 8. Probably not the most difficult case we have ever done, but it can be done.
Dr. Chapin, do you agree with that? Would you recommend ablation, or what would you recommend for this patient?
Given the medical comorbidities, I don't think it's unreasonable to consider a period of active surveillance. However, one question that comes up a lot when you're looking at active surveillance, and I know with Dr. Mateen's protocol here, we offer patients the possibility of a biopsy to get a diagnosis prior to doing active surveillance. And I don't know what the finding would change unless it was benign, in which case you'd feel a lot more comfortable with active surveillance. But I don't know if there'd be a finding that would cause you to act. But that is a possibility, and I would probably recommend active surveillance for a period of time.
So active surveillance for a period of time. Who would do a biopsy? Of all the panel members, raise your hand. Who would do a biopsy of the lesion? So we got two people for biopsy. Dr. Mateen, why would you do a biopsy? What would you learn from that, and how would it help your management?
So I think there's two issues with that. One is you're looking for reasons to justify not doing something aggressive and potentially unnecessary surgery for someone who may have very little to gain from it. So if we do a biopsy and show that it's benign, then really there's no need to do anything. And you can even make an argument to not follow it, but we do, because even if they're benign, they can grow, but they're probably not going to cause any harm for the most part. Now, there are some cases where it shows, the likelihood is that it's cancer. I'm not sure we need to go over that with you all, but if we just look at a mass like this, depending on the age of the patient and their gender, there's anywhere between a 60 to 80% chance of it actually being kidney cancer. Okay, so there's a chance it could be benign. But even within the realm of kidney cancer, there's different types of behavior. So if the biopsy shows that it's a chromophobe kidney cancer, for example, those are what I tell patients are reluctant cancers in some ways, in the sense that they sometimes will grow, but their ability to invade or spread and actually cause demise in the patient is very unlikely. They can get huge and not spread. So I think it does help. Even for patients where we know it won't make a difference, we've decided on surveillance. My justification for recommending a biopsy is that you have a right to know what you have. You have a right to know if you have cancer or not. And I think it allows us to be proactive so that when we're watching it and it grows in ways that we don't expect, we know what we're dealing with. And I think it's better for me because then I can have a plan in mind. And I think for the patient, the worst thing is the fear of the unknown. And so when you know what it is and you know what's happening and you know that some decisions will be made based on that, I just think psychologically it's much easier to deal with. So.
All right, so let's say we went ahead and did a biopsy, and the biopsy came back as clear cell renal cell carcinoma, Fuhrman's grade 2. So the medical oncologists on the panel get to be surgeons for a day. You lucky guys. Let's go ahead and vote. Who would do partial nephrectomy?
What did we say her kidney function was?
Her EGFR is about 60.
Okay. So you want to explain what kind of?
Oh, you.
Right. So that's basically a global measure of the function of both her kidneys. And as you can see, the left kidney doesn't look very healthy. It's kind of small compared to the right one. So it's likely that we're looking at her one good kidney. So her total function of 60 is right borderline of what we consider normal. So less than that is 59 would be considered chronic kidney disease, meaning her kidneys are not functioning properly, which you expect in a 74-year-old with all those medical issues also. And so that's something to keep in mind. Probably the worst thing we could do for this patient is risk dialysis. So that's just an important thing to kind of keep in mind, because as probably many of you all know, everything we decide, decisions we make jointly, there's a trade-off. So even doing nothing has a trade-off, right? So that's an important consideration in terms of the kidney function. And it's something you'll hear us asking frequently for these cases.
So her EGFR is 60. So who would recommend active surveillance? It's because you guys looked at the slides. Who would recommend partial nephrectomy? Who would recommend ablation? The lone ablation. Okay, so Cameron, why would you recommend ablation?
Well, I think it's the least invasive, and as Dr. Mateen said, you worry about kidney function, and studies have shown that ablation, everything we do to the kidney has a side effect and causes some deterioration of the kidney function, but ablation has been shown the least problematic or cause the least amount of decline in the kidney function compared to nephrectomy, partial nephrectomy, and other. So, if we decided to do something actively other than surveillance, then I would recommend starting with ablation.
Okay, so the patient did undergo a biopsy, and the biopsy did show clear cell renal cell carcinoma, nuclear grade 2. The patient and her doctor elected to pursue active surveillance because of her comorbidities. And then she comes back 1 year later for imaging. And you can see that the tumor has increased in size. Now, Serena, you published significant material in the active surveillance literature. Is this increase in size consistent with what's published in the literature with regards to growth of a tumor?
Yeah, I didn't get a size measurement from you.
Bigger.
But it's
bigger.
But so generally, if it's a half centimeter,
it's 6 millimeters bigger.
yeah.
Okay?
So I was going to say it looks a little bit more than that. So that's a bit of a concern. It's not based on anything really scientific in the sense that we think that behavior. It's just basically somewhat arbitrary. But it is whatever it is, the information we have. So yeah, it is a concern that it's grown. And I would be uncomfortable with continued active surveillance, assuming there's been no other changes in her other medical
Everything's pretty much
conditions.
stable.
Right.
So what would you do?
Yeah, so I would have a talk with her about treating it with
And she'd say, whatever you say, Dr. Mateen.
Of course, yeah. And the options are just like before, a partial versus ablation. I would ask Cameron to take a look at the films and see how comfortable he would be with ablative therapy because it's gotten a little bit harder now than before.
And luckily, Cameron's sitting right next to you. Cameron, take a look at the films. What do you think?
So, you have to realize when we measure tumors on a two-dimensional CT scan, we're measuring diameters of the tumor. So this tumor has grown from, let's say, a diameter of 3 centimeter to 4 centimeter, but the volume of it has dramatically larger to a factor of 3. So the volume that we have to treat this kind of central tumor abutting the hilum would become very difficult. In our experience, most of the patients that we have observed, and occasionally their tumor has grown, we have been able to do ablation, but this is one that I would hesitate to say that I can easily get margin at this point. So there comes a point, we're just watching and waiting. There comes a point where you cross that bridge and you say, well, I'm not as confident now that I can do as good a job as I could have done about a year ago.
Okay. So
Can I ask you a question?
you can ask me anything you want.
Would 1 year be the period of time that you would follow up someone for active surveillance typically?
No, typically we'd see it every 6 months. We would see her every 6 months, but she was lost to follow-up and came back at a year. Dr. Delacroix, this patient shows up in New Orleans. What are you going to offer him?
A open right partial nephrectomy.
Okay, you would not consider ablation?
My intervention, I don't have Cameron. My interventional radiologist, that's a difficult ablation. So I think it would be a right open partial nephrectomy.
All right, so let's take a poll. Who would recommend active surveillance? Continued. Who would recommend partial nephrectomy? Because you've all seen the slides.
Honestly, I don't remember the cases because you have so many. Like I just
Who would
remember the
recommend
details.
ablation? Okay, so the patient undergoes partial nephrectomy, and it's a T1A, N0, M0, Fuhrman's grade 3, clear cell renal cell carcinoma. So T1A just means 4 centimeters or less confined to the kidney, so it's a localized tumor. So, Dr.
Chris, can I point out something?
Absolutely.
To the point that Serena brought up about biopsy, this is a tumor that's nuclear grade 3. Hardly ever you see nuclear grade 1 or 2 grow this fast. So if you had a biopsy ahead of time when we were observing this patient, you'd be a little bit more careful probably about following this if somebody had a grade 3 or 4 nuclear grade.
That's a good point, actually. Dr. Crum, why don't you explain for the audience what we mean by nuclear grade? What does it add to the equation?
So Fuhrman grading, basically the pathologist who devised the system, his last name is Fuhrman. The grading system is based on how the cells look under the microscope. So there's grades 1, 2, 3, 4, 1 being the lowest grade and 4 being the highest. So if the cells look almost normal or barely cancerous, that would be a grade 1. If they look very unusual or very abnormal, that would be a grade 4. And the higher the grade, the more aggressive the tumor is as far as how quickly it grows, how quickly it metastasizes, or how quickly it invades other structures. So that's what Dr. Arar was mentioning. If we know it's a grade 3 or 4, we have to be very careful and maybe follow the patient much more closely because of the higher risk of quick growth.
So Dr. Chapin, since you made a recommendation regarding follow-up for active surveillance, perhaps you'd like to make a recommendation for follow-up after surgery?
In this case or in any case?
In this case.
In this case, I typically would I'd follow up with a CT scan imaging about 6 months post-op. I would do a CT abdomen and pelvis, and then laboratory work. I'd do a complete metabolic panel, an LDH, and I've been getting urine protein creatinine ratios, but that's basically because of your recommendation, and I haven't really seen that they've directed my post-op management at all.
Would you get any chest imaging of any kind?
I mean, I probably initially would get a chest X-ray the first time around, and then I wouldn't follow up any further with the chest beyond that.
All right, so you're saying you would see this patient every 6 months with a CAT scan and labs. Is that what you're saying?
For the first 2 years, yeah.
For the first 2 years?
And then probably
what?
yearly thereafter.
Yearly thereafter. Dr. Karam, do you agree with that strategy?
I think that's a bit too aggressive of a follow-up for a stage 1 renal cell. I would agree with Dr. Chapin as far as getting something at 6 months, including a CT scan, chest X-ray, and labs. But as far as abdominal imaging, I think we can get another one about 1 year or 2 years after the initial one. And I think the chest X-ray is the one that needs to be more frequently done, maybe every 6 to 12 months, given that this is the more common place it would go. And it's comforting to know that the margins were negative and it's a stage 1, so I would be less worried about a local recurrence in that kidney.
So, Dr. Delacroix, the patient comes to you and they have Time magazine in their hand and they show you the article that says that they're going to glow in the dark from so many CAT scans that Dr. Chapin wants to order. So what would be your recommendation?
I disagree with the guy on my left and my right.
Not surprising.
Yeah. At 6 months, I'd get cross-sectional imaging. I'd get a CT scan just to reestablish a baseline, look what the defect was. I mean, you have negative margins in there, and I'd also get a chest X-ray. And after that, I'd just follow the patient with renal ultrasounds and no other imaging.
Dr. Mateen, how would you follow this patient?
I disagree with all three of them.
So you can see this.
And so,
this is an art, not a science.
Yeah, no, and so I think one thing, just to take a more global view on this, you're going to hopefully hear us disagree on a number of items, and we usually do. And I think, hopefully it'll give you a sense for how much there's a lot of gray zones in medicine, and specifically in urology, as far as today goes, in kidney cancer. But this issue of follow-up and how we follow up is really an area of need that we have in terms of getting it more standardized. The AUA is actually coming up with a set of recommendations, and I had the opportunity to review them. I could not disagree with them more because, unfortunately, it's just expert opinion and not really based on evidence as much. So if we look at the evidence, the likelihood of abdominal recurrence, so anywhere in the abdomen, kidney, liver, lymph nodes, anything like that, for something like this is less than 5%. Basically, her overall risk of recurrence is less than 5%. Within that 5%, the greatest risk, as Dr. Karam pointed out, is in the chest. So the place you want to look is the chest, and the chest X-ray is minimal dosage of radiation compared to a CT scan, and no evidence that doing a CT of the chest leads to better outcomes than a chest X-ray. We do tend to be more aggressive in patients who we think are going to have more aggressive cancer, but the truth is that's never been shown. So you're getting about 200 times more radiation dose for CT of the chest. In terms of the CT of the abdomen, when you're looking at 1% or less likelihood of recurrence, and doing that, for my practice, this patient would get a CT scan. Actually, now I'm doing it at 1 year only because I get the pressure from everybody saying that, oh my God, you have to have one. But the truth is, up until a few years ago, I was ordering them maybe 2 or 3 years later. They can get a baseline then because the likelihood of any recurrence being there is almost nil. And in the rare cases where you see a recurrence at 3 years, I never think, oh my gosh, I wish we had a baseline. So this whole concept of having a baseline CT makes no sense to me. And unfortunately, I think it's one of the many things that we default on because we're insecure. We're insecure about a variety of factors. Some of them about feeling like we're shortchanging the patient, some of them because of liability concerns. And so I think, again, taking a global view, this is one of the many little things that adds up to the, $2 billion care for kidney cancer, that we have. And then on top of that, you add to the total issue in terms of cost of medicine. So I've gone from 30,000 feet down to 1-inch view. But, my point being, I think if you look at the data, all really she needs is a chest x-ray, I would say maybe every 6 months in the first year because it's a grade 3. After that, once a year, and I'd get a CT scan at 2 or 3 years.
Yeah, in my practice, basically at 1 year, I get a CT and chest X-ray and follow them yearly. I don't see them every 6 months. Cameron, since you're here and are an expert radiologist, maybe you could comment on the value of ultrasound versus CT scan versus MRI for imaging the abdomen, imaging the kidney, looking for evidence of recurrence. As you know, in Europe, ultrasound is primarily used as in follow-up for patients.
Correct. So there are some limitations. We have great imaging compared to 20, 30 years ago where we had only X-ray. We have great imaging. Diagnostic imaging has made great progress. We have CT, we have MRI, and we have ultrasound. And all of them are good. None of them, not a single modality is perfect. So every time you decide that I want to image something, you have to decide, okay, what are the pros and cons of imaging something? In a thin individual, you can do ultrasound. Ultrasound is great for individuals that are thin. You can see the kidney. If a person is larger body habitus, has a larger body habitus, ultrasound becomes very difficult. CT is great because it's easy to perform. MRI is a bit more difficult and varies. The quality of MRI varies from institution to institution and from the equipment that an institution may have. So for the most part, most of the time we do CT scan. The downside of CT is radiation and also iodine. Iodine is not really friendly to kidneys, and there is a point where the kidney function goes lower than certain limit, and we really dislike or do not like to give iodine. So at that point, MRI becomes, a good option, a second option. So, and recently you've seen the Time magazine and other articles that have been out about the risks of radiation over long term. Yes, those risks are real, although still very low. And I think the benefits that we get from appropriately sanctioned imaging is much better, much higher than the risk of cancer that they cause. I think those are all good considerations. If you have good imaging, good MRI imaging, I think MRI is a good way to go. In Europe, ultrasound has made headways, and they use ultrasound quite a bit. In the Far East, also, they use ultrasound a lot, but they have other things that we don't have available. For example, contrast-enhanced ultrasound is a technology that's available in Europe, but FDA has not approved it in this country, so we don't have contrast-enhanced ultrasound. It will come eventually.
So 30 months later, she presents for her annual follow-up. She's now 78 years old. No significant complaints. She's still in her wheelchair. Pulmonary fibrosis is still stable, and a CT is obtained, and you can see that now she has a tumor in her atrophic left kidney. Dr. Karam, what are you going to do for this patient?
I would check renal function of this patient with a nuclear scan to see how much the left kidney is contributing. Like Dr. Mateen mentioned earlier, it looks like the left kidney is much smaller. So I would like to know that information before deciding. Ultimately, the realistic option would be either surveillance or partial nephrectomy or radical nephrectomy. I don't think this is a good position for ablation, but Dr. Arar might want to comment on that.
So the renal scan is going to tell you what, and how are you going to use that information?
So if the renal scan tells me the left kidney is contributing about 10 or 15% of the total kidney function of this patient, we can do left radical nephrectomy. If the left kidney is contributing more than 20 or 30% of the global function, I think we need to do a kidney-sparing approach. So that would be a left partial nephrectomy.
Okay, let's say it's contributing 25%. We just got the renal scan. Results are in.
So active surveillance or partial nephrectomy. If the patient tells me whatever you think, doc, then we would go for a left open partial nephrectomy or left robotic partial nephrectomy.
Who else would consider active surveillance in this patient?
What's the size of it now?
Let's say it's about 3 centimeters. Anyone else? Dr. Karam, you're the lone wolf that would consider active surveillance. You want to defend yourself?
Well, if the patient, I mean, it's at the upper limit, but if the patient is willing to do it, I think we can watch it, but we would have to do it more closely, not to bring her back in a year. Probably repeat the scan in 4 to 6 months and see if the mass has grown.
Just wondering, maybe for their purposes, you want to explain what you mean by the 3 being at the upper limit?
So there is a loose definition of small renal masses. It's basically any mass in the kidney that is less than 3 or 4 centimeters. So anything less than 3 or 4 centimeters, we would call it a small renal mass. So if the mass is 5 centimeters, we typically do not observe it. If it's 1 or 2, we would definitely consider it. 3 or 4 is at the upper limit, so we're not as comfortable offering that to the patient as far as the treatment option. And this patient falls in that category of the gray zone of the observation category.
I guess my concern about this is that, so this woman has been followed for 30 months since surgery. So do the math, she got a CAT scan once a year, so this is her second CAT scan. And presumably we looked at the first CAT scan and it didn't have a tumor, and now we're looking at the CAT scan and we get a 3 centimeter tumor. Does that bother you at all?
Well, there's a lot of assumptions there, but yes, it does bother me if this has grown in 1 year. There's also something in the liver. I don't know if that's anything real, but I'm assuming that you're discussing here, that's the only site of disease. So in that case, if it's grown in a year, I'd recommend partial nephrectomy.
Okay, so let's survey the panel. I think we beat this one to death. Who would recommend partial nephrectomy?
Depending, yeah.
Who would recommend ablation? Who would recommend active surveillance? Who would recommend we move on? All right.
Before, Chris, can we have the medical oncology?
By all means,
Medical oncologist, the view on this.
weigh in.
First, I think, for the panelists who recommended biopsy for this lady at the initial, time with a mass in the right kidney, and, if this will guide you to decide whether you're going to intervene with surgery or not based on the FNA, fine needle aspiration or biopsy, there is discordance between the fine needle aspiration biopsy and the final pathology from nephrectomy. So while there is a good concordance with the type benign or malignant and the type clear cell or none, but I think to decide on the grade, there is discordance. Would you like to comment on that? I think, you may get a Furman nuclear grade 2 thinking this is low grade on the biopsy, and then it'll be grade 3 or vice versa.
Right.
So that's a point, I think, to be made. That's why I do not think I was of the opinion to observe this lady initially, and therefore I would not have done the biopsy anyway. The second point about the follow-ups, I am a minimalist, so in terms of doing surveillance studies, and I agree totally with Dr. Mateen. And the reason, the medical oncologist viewpoint here, is that you're doing those surveillance studies with scans, whether you decide to do them yearly or every 6 months, is if you find something, you're going to do something about it, right? So if you're going to intervene, I think the question is, what are the systemic therapy options for this lady who is 74, who is on steroids, who has pulmonary fibrosis, who is wheelchair bound? And so I think, in my view, I would be minimalist in the testing, because I do not think this lady, if she developed lung metastasis, I'm going to jump quickly and treat her with systemic therapy. In my view, with her lung disease, she would not be a candidate for metastasectomy if she had lung metastasis, and we know that this is the most common site for metastasis. So, and we have many patients with systemic disease with metastasis to lungs or lymph nodes that we observe. So I think observing patients with active disease is still an option, and therefore, if I do not think we're going to intervene treating this lady, I would minimize the testing. So
Fair enough. Serena, a common question that we always get, and you know this, is, after partial nephrectomy, patients say, what's the likelihood my tumor is going to come back in that kidney, and what's the likelihood that I'm going to get a tumor in my other kidney? So what do you tell your patients?
Well, I thought I kind of went over that a little bit, but in terms of, the likelihood of recurrence in the abdomen because of the first cancer, in terms of it having spread, is really very low. Now, the risk of developing bilateral disease is still pretty low, single-digit percentages. Typically, you see it more with the papillary type but it depends on how you look at it. The papillary subtype of kidney cancer is much more frequent than the others to be multifocal, multiple places in the same kidney, as well as being bilateral. But the fact is, clear cell is so common, it's 80% of all kidney cancers, that because even though the bilaterality occurs somewhere around 5 to 8%, you just see that more often. So, I mean, it's pretty uncommon. Now, having said that, to clarify a little bit about what I said before in terms of the CT imaging, if there is something that is kind of funny on the initial scans, then you should do it a little bit more frequently. And in fact, we go back and look at her imaging study. She did have something that was a little bit abnormal in that left kidney. And so it's likely that this was probably there. It was just small and not quite like that. And so does that answer your question?
Yeah, I mean, I think the issues are, after partial nephrectomy, the risk of recurrence in the same kidney is at less than 5%.
Oh, yeah, I'm sorry, yeah.
The risk of bilateral disease is 5% or less. And, suppose they have let's change this a little bit. Let's say they have a chromophobe kidney cancer on the right kidney. What do you tell patients the likelihood is that the contralateral tumor is going to be a chromophobe?
Yeah, so I think the concordance is pretty high.
It's about 70%.
Yeah, so it's likely to be whatever it was on the other side. Occasionally, it's not.
I think it's important also for the audience to really know this, because they ask this question all the time. Sometimes we cannot really be certain whether the tumor on the other side, especially if it's small, whether it is metastasis from the original tumor or whether it's a de novo tumor arising in the remaining kidney. So I think, often we may not be able to tell unless it's a big-sized tumor favoring that this is a de novo tumor. But if it's a small 2-3 centimeter, it could still be metastasis from the original tumor.
Very rare, though. That's really rare.
I'm sorry?
That's really rare.
Okay, yeah. Okay, let's move on. 51-year-old Hispanic male presents with gross hematuria. He's got a past medical history significant for diabetes, hypertension, gout, and kidney stones. He has a past surgical history only significant for fixing an inguinal hernia. He takes metformin for his diabetes, lisinopril and sertraline for his blood pressure, and simvastatin for his hypercholesterolemia. His mother, his father, and his brother all had kidney cancer. And his father died from metastatic disease. He doesn't drink, he doesn't smoke, he has 2 kids. His CT chest is negative, and his labs are within normal limits. Now you can see here he's got this very, very large tumor involving his right kidney. And in addition, he has a smaller tumor involving his left kidney. Here's another view. Again, large tumor involving the right kidney, small tumor involving the left kidney. Here's a coronal view.
While you guys are looking at that.
Smaller.
Yeah.
Smaller. That's still a big tumor.
Just so you don't think Dr. Wood is saying that it grosses him out, but the gross is a term we use in terms of visible, meaning you don't need microns. So I don't know how many of you guys are familiar with that terminology. He's not saying he's grossed out by it.
All right. So let's see. Dr. Chapin, this patient comes to you. So large tumor right kidney, smaller tumor left kidney, no metastatic disease. Mother, father, brother have had kidney cancer. Father died of kidney cancer. What are you going to do?
I think based on the size of the right tumor and the risk for that becoming metastatic or the source of metastases, I would probably do the right kidney first, followed by a left partial nephrectomy.
Why not do
choice
both?
one at the same time?
Yeah, why not do both at the same time?
I just think it's a lot for the patient to handle at having it both at the same time. If you have the contralateral kidney, the left kidney still in situ, then you can hope that postoperatively he'll recover faster than if you took both kidneys out and put him on dialysis or renal replacement therapy.
Jose, do you agree with that?
I would choose number 1 too, but I think on the left side we should definitely try to do a partial nephrectomy. But what Dr. Chapin mentioned is dialysis. Temporary dialysis in case you do a partial nephrectomy and you've lost kidney function on the same day from the right side. But I agree with Dr. Chapin. I would do a right nephrectomy first because of the higher risk of metastasis or spread from the right side. And then about 6 to 8 weeks later, follow that with a left partial nephrectomy.
Scott, what do you think?
we talk about this a lot, and I don't think there's a right answer here. Actually, what I would do would be an open left partial nephrectomy first. Because that right kidney, if the right kidney was entirely tumor, when you look at the coronals, there's actually some normal parenchyma a little bit at the top and the bottom. So I'd do the big open left partial nephrectomy, salvage that kidney, and then have my right kidney there to, I know it's got a large tumor in it, but have the right kidney there to back me up as the patient recovers. And within 8 weeks, I'm going to be taking out the right kidney. So within 8 weeks, he's going to get both of them treated.
Would anyone consider biopsy? Would that help in any way?
I don't think it's going to change the management whatsoever.
Okay.
Not unless it's a protocol.
Right, unless you're going to put them on clinical
Nazar or
trial.
Michael, do you want to comment on the role of targeted therapy in this setting? Would anyone consider giving this patient targeted therapy to try and shrink the tumors or eliminate metastatic disease or micrometastases?
In the absence of metastatic disease, I do not recommend systemic therapy up front. Only if the patient has metastasis or if after surgery the patient develops recurrence. I think a comment to be made here, this is a patient with 3 bloodlines having RCC. One has to consider this being an inherited syndrome. So bilaterality, father, mother, and brother had renal cell carcinoma. I think he needs to be evaluated at the genetics clinic to rule out this being a VHL disease, VHL, von Hippel-Lindau inherited syndrome. In terms of approaches, I agree. I think the one that's most threatening is the right side, so one would take care of that first and then the left partial. Although there are surgeons, urologists, at the Mayo Clinic who have done or still advocate doing both surgeries at the same time.
Yeah, I think conventional wisdom in urology is to do stage procedures, and then it becomes a real controversy in terms of how you stage it. So, both of the arguments are valid. On the right side, there's a locally advanced tumor. You worry about it metastasizing. But on the left side, there's a fairly large tumor that's not going to be a chip shot partial. And you're concerned that if you take out the right kidney and then do the left kidney, that if the left kidney goes into shutdown, the patient ends up on dialysis. Conversely, you could do a partial nephrectomy on the left side, but if they have a complication or something that delays their subsequent surgery, they could metastasize on the right side. So you can see it's no easy answers and can sometimes be really challenging to make those decisions. Well, ultimately, I can tell you that the patient underwent a left partial nephrectomy. It turned out to be a clear cell renal cell carcinoma, T1B, and then a right radical nephrectomy. It turned out to be a T3A, meaning it was invading into the renal sinus and the perinephric fat, clear cell renal cell carcinoma grade 3. So then, Michael or Nazar, would you like to comment on the role of adjuvant therapy, meaning that after completing these 2 surgeries, the patient comes to you and says, my father died of kidney cancer. Is there any medicine that you can give me that can make sure that I don't die of kidney cancer?
Sure, I can take that one. So my answer to the patient would be off of a protocol, there's really no role for adjuvant therapy. Now, this patient is high risk, and we know that we have lots of active targeted therapies. We have 7 FDA-approved agents, in the last 6-7 years now. So we know that we have active agents, but it's really not clear off of a protocol what the role of that is. So I would encourage that patient, if they were eligible, to enroll on a clinical trial protocol that was appropriate.
And do you know the clinical trials that are available currently in the United States?
Yeah, there are several that in the past several years. I'm not sure what you all have here. We have a PROTECT study that's looking at adjuvant pazopanib. There has been ASSURE that's looked at sunitinib or sorafenib. There's been STRAC. There's been all different ones. Everest, looking at everolimus.
Yeah, the 2 currently open trials in the United States are the Everest trial, which is sponsored by SWOG, which randomizes patients to everolimus versus placebo, and then the PROTECT trial, which is sponsored by GSK and randomizes patients to pazopanib versus placebo.
Well, the question, there is one adjuvant study that has shown to be a benefit, and it's never been replicated. It was a tumor-derived vaccine from Germany. So would you have enrolled this gentleman on a vaccine trial before you took out his kidney?
If one existed, but as you're well aware, that there's controversy surrounding that study because the intent to treat analysis was negative. It was only when they looked at patients who actually got the vaccine and the trial was empowered to show that. But you're right, there is a vaccine preparation in Germany that potentially could decrease the risk of recurrence, but I don't think that's going anywhere, as I understand it.
Just to comment on the concept of randomized. So when we say randomized, basically we randomly choose. There is a certain computerized process that tells us if the patient's going to take the medication or the placebo, or otherwise known as a sugar pill, for example. So the doctor or the patient, we don't choose what medication the patient's going to receive. So the patient needs to know that they could be on a non-active medication or on the active medication, and it's completely random process.
All right, let's move on. This is a 57-year-old African-American female who, again, presented with abdominal pain. She has a history of hypertension, sleep apnea. She had a heart attack back in April of 2012. She's never had surgery. Medications include metoprolol. She takes an aspirin. She takes drugs for her cholesterol. Her CT chest is negative, and her laboratory studies are all within normal limits. And you can see here, she's got a tumor that's basically completely inside the renal parenchyma here. And then she's got another tumor. You would think bilateral tumors are running rampant in Houston, but they're not. Another tumor present here in the left kidney. So first, maybe, Serena, could you just make a comment about the nephrometry score and how we use that and what the value of that is in terms of communicating about the complexity of tumors?
Yeah, so the nephrometry score was developed actually by somebody I used to work with, Rob Uzo, and his team. So it's a way for us to put a number on how difficult a partial nephrectomy is going to be, or basically how complex is this tumor, which is really a great advance. Because up until then, it was all description. Well, it's deep in the kidney, or it's this big, and there was really no way for us to have an objective number that you could translate that would mean the same thing in Houston as it would in Chicago, as it would in Sri Lanka. So, but now we have that, and basically it's a way of looking at tumor size, where the tumor is located in terms of how deep it is in the kidney. So the deeper it is, the harder it is to remove, and the higher the risk of complications, for example. How close it is to the urinary collecting system, which you can't really see on these scans, but maybe later, if we have some scans that have an excretory view, we can show you. But for example, the right-sided tumor, maybe Chris can point out with the mouse, it's probably contacting where the urine is collecting. And so that increases the risks of surgery a little bit. And then there's one more. Oh, and also how close it is to the hilum, which is the, if you will, the heart of the kidney, right where all the blood vessels come in. So if you look at those 5 factors, you assign a number, 1 to 3, in terms of how difficulty, and then you add it up. So if a tumor has a complexity of 6, it's not that complex. If it has a complexity of 9, 10, 11, it's really pretty complex.
Cameron, do you want to comment on maybe the role of ablation here? Would you consider ablating one or both of these tumors?
I think that both can be done. I mean, again, you need to think about the size and the location. So if both of these, they look like they both measure less than 4 centimeters. They're both on the difficult end of the spectrum. Similar to the nephrometry score, people have tried to establish criteria for ablation. And the same principles apply to ablation. How big is the tumor? Where is it located? How close is it to the center of the kidney? Both of these would have probably high score on that nephrometry score, if you will. But yes, they can be done.
All right. Dr. Delacroix, how would this patient be treated in New Orleans?
She would get a bilateral partial nephrectomies.
Okay. Which side first?
Left side first.
Why?
Because it's easier. It's got a lower nephrometry score. We would do a left side, and we'd probably attempt that robotically. And then the right side would be an open partial.
Okay. Dr. Chapin, how would you approach the patient?
I agree. I mean, bilateral partials, I would do the left one first because it's easier. And if I know that I'm safe with the left kidney going to the right kidney, I don't feel as anxious about the difficulty level of the right partial. I would probably do both of these open. I actually wouldn't do these robotic or laparoscopic just because of the bilaterality. If the right kidney did not have a tumor, I might attempt the left one robotically, but that's also a matter of experience.
And so the idea of choosing the easy one first, just help me out with that. What do you mean? Why?
nothing scientifically based. I mean, that's again, it goes back surgeon preference. I can't point
Well,
to.
I think it's convention to some degree in the sense that the issue is preserving kidney. And so if you do the easy side, meaning there's confidence that you can preserve the kidney, then you're not putting yourself behind the 8 ball when you go to the other side. And if you think there's a higher risk of having to remove that kidney, you know you've got money in the bank with the other side. That's sort of, it's a philosophical thing. It's not scientific, really. But that's kind of what it is. It's really setting, saying yourself, but I mean the patient, of course, but trying to set the patient up for success in terms of kidney preservation.
How long between operations?
Well, I mean, I think that's also a point to be made of this complexity in which one you're choosing first. If you were to do the right one first, and if you were to have a prolonged urine leak, or if you really wanted to be clear of the one side being complete before doing the opposite side, I think your time between surgeries would be lower if you do the easier or less complex kidney first. So therefore, if you don't have a prolonged drain and prolonged urine leak and issues that can come with doing a partial that's more complex. So, if I were to do the left one first, and the patient is a 57-year-old, could relatively recover quickly, I would probably schedule the right side within 4 to 6 weeks.
Okay. Of course, Dr. Chapin, we know you never have complications, so that would work out. Dr. Arar, would you ablate both at the same time, or would you stage them? And if so, how would you stage them, and what's the time frame?
No, we would stage them. We have treated occasionally bilateral tumors, but if they're very small and they're very easy to access, we do treat these patients under general anesthesia. It helps the procedure. The procedure can be long, 2 to 3 hours, can be painful during the procedure. Although other centers across the country use moderate sedation without the use of general anesthesia, but I personally would not recommend it. I would stage it, and it really doesn't matter, either one.
Okay. So the patient unfortunately went to an outside hospital and was counseled to undergo robotic-assisted laparoscopic left partial nephrectomy, the quote-unquote easy side, followed by an attempted robotic partial on the right. The surgeon apparently found the left tumor to be, quote, more complex, end quote, at surgery, and that actually turned out to be a 9-hour case. The pathology came back as unclassified renal cell carcinoma, Fuhrman grade 3. All margins were positive. Basically, they just chopped this thing out, and all the margins were positive. So, and just for the audience, margins means we look to see where we cut to be sure that there's normal tissue there, because that implies that the entire tumor was removed. But if we look where we cut and we see cancer, the implication is that cancer is still left behind. So in this particular patient, all the margins were positive, implying that there could still be cancer cells left behind. So her surgeon, after this 9-hour case, said, maybe we'll just watch that right side for a while. Dr. Delacroix, do you agree with that? What would you counsel this patient?
A second opinion would be good. And another thing, a 9-hour robotic procedure, I mean, there's a point where principles of oncology need to preempt the way in which a procedure is done. If it's a 9-hour case, you really need to be thinking about just doing it traditionally, opening the patient and doing what's right for the patient. Because completing this, obviously, robotically, has left positive margins in this patient. It's going to be something that we'll have to deal with. So when you look at patients who have positive surgical margins, albeit most of them are microscopic margins, and I'm betting that this was grossly positive, most patients who have microscopic positive margins after partial nephrectomies for small masses will not recur. And you're talking 90+% of them will not recur. So it is safe to watch them. The first thing I would do would be to re-image the patient. As long as I don't see anything in the operative, on the left kidney where she was operated on, I would go ahead and complete the contralateral kidney. Just do a period of surveillance for this side.
All right, so the patient comes 4 months after her left-sided surgery, no interval changes in her medical condition, CT negative, labs are within normal limits. There's your repeat imaging. So just for the audience view, you can see here's the tumor in the right kidney still sitting there. And this is the area where the partial nephrectomy was performed. If you see that white stuff, that's contrast. That's where they injected the contrast into the vein. and it's excreted by the kidney. So she has what looks like a little bit of a urine leak in the site where the partial nephrectomy was performed, but there's no obvious tumor present. No obvious tumor. Dr. Karam.
What's in the abdominal wall there,
Yes.
Chris?
That nodule on the left side?
Oh, this?
Yes.
That's nothing. Don't worry about it.
That's a port site.
Yeah, it's probably a port site on the robot. Dr. Karam.
Yes. So I would love to see the same type of images that you have on the left, on the right side as well. So you showed the excretory, which is the late phase of the CT on the right side. But it would be nice to see the same view earlier on, just to see if there's any enhancing elements, or basically to see if there's any viable tumor still left on the operated side.
There doesn't appear to be any evidence of viable tumor on the operative side. Take my word for it.
So in that case, we'll just proceed with the right-sided operation.
Okay, and that operation would be?
A right open partial nephrectomy with ultrasound.
Okay. Dr. Mateen, what are your thoughts on this?
No, I agree. I think you still want to give it your all for this. I have great concerns about follow-up over the next 6 months to 2 years, and 5 years really. But no, I think I would do an open partial also. I'm sure at this point she probably has no interest in anything robotic anyway. But I think Dr. Delacroix's point, that it's nice to be able to do something minimally invasive, but it doesn't trump the need to do the single best cancer operation you can. So that's really takes priority.
So are we all in agreement that we would do a right partial nephrectomy? Yeah?
Yeah.
What about the left side? What would we do for that?
So just to clarify in
There you
terms
go,
of
Dr.
positive
Brown.
margins, so microscopic positive margins in kidney cancer seem to have very minimal implications. So if there's like a 1 millimeter positive margin, those patients seem to do really well. The risk of recurrence seems to be probably close to someone who has a negative margin. Now, in this case, though, it's probably what we would call grossly positive margins, meaning visibly positive. And that's a totally different situation. Unfortunately, the truth is there's nothing we can really do. You could go back in, take out all of that tissue and not find any cancer. It does not mean that she would not have recurred. You could go in, take all of that tissue, and it does not mean that she won't recur. It sounds like I said the same thing, but actually I was trying to make a different point. But someone with grossly positive margins really is at risk for recurrence, and I think it's like a 7-fold risk of them developing it and dying from it. So I would watch her very carefully. This would not be a case where I would follow with a CT in 2 or 3 years. I would be following her much more closely.
Any role for just taking out the left kidney and eliminating as a risk?
Why don't I give one of the other guys a chance to answer that?
Not at this point. I would want to see what happens with the right side to make sure that the partial nephrectomy was successful with negative margins and with preserving of the right kidney. But it is worrisome that the patient has the unclassified type of kidney cancer. Basically, like Dr. Mateen mentioned earlier, about 70 or 80% of the kidney cancers are clear cell, and the rest are papillary or chromophobe. Unclassified is probably less than 5%. And when the pathologist says it's unclassified, it means it doesn't fall into the other known categories. And these are typically aggressive tumors for the most part.
Okay, so the patient will
I'm
undergo...
sorry, Chris, but to answer your question,
Yeah.
and I think this is one of the things that's difficult for patients to accept, is the problem with just going in and taking out everything on the left side is you don't really know what to take out. The scar tissue feels like cancer. You're not going to be able to tell by looking or feeling, and you don't really know how much spread there's been. And then the other thing is you don't know if you don't want to make things worse because you don't know where things are or how to differentiate cancer from scar tissue. So the last thing you want to go in is add insult to injury by going in. Does that make sense? Mm-hmm. I don't know if I'm expressing myself well, but you and I have been there where you've sensed the frustration of the patient wanting to do something, and you want to too, but it's usually not a good idea to do that.
Any role for biopsy? Would you try maybe biopsying that left side?
The sampling is going to be a problem. You don't know where to put the needle.
What about targeted agents, Dr. Munir? Any role for targeted agents?
No,
in this
as
setting?
we said earlier no.
All right, let's move on.
It's a funny idea, that, I mean, really what we're talking about is in terms of agents. I'm sorry, I'm probably being a little verbose, but it's kind of interesting.
Yeah.
Don't answer that. You would think when you see a lesion, a metastatic lesion, you would think that if a drug works for that it should work better for when it's microscopic and you don't see it, right? I mean, you would think, but it doesn't work that way. And because that's really when you're talking about additional therapy, you're talking about microscopic disease that's hibernating somewhere that we just cannot detect. I mean, that's why patients with breast cancer don't just have surgery or just don't have radiation. They have chemo, radiation, surgery, hormone therapy, because breast cancer does that. It tends to spread very easily, and there's microscopic disease, and for them, thankfully, there's agents that work for that. For kidney, there isn't. Why is that?
Yeah. Can you give us a follow-up on what happened to that lady?
She underwent a right partial nephrectomy. It was an unclassified tumor. Margins were negative. Kidney did fine. And then she's being observed on the left side.
Okay.
And Nizar, why don't you comment on why it is that maybe these targeted agents are not very effective, or we believe they're not going to be effective in the setting of micrometastatic disease?
Well, because probably there is the way these drugs work is most of these target therapies we're talking about are angiogenesis inhibitors, and it requires a metastatic phenotype with advancing progressive disease where these drugs can work. And maybe when it's still in the primary tumor, the milieu is such that it doesn't really help as much. Although we have seen, your trial, you will probably, I'm sure there will be some cases where you have a trial with a drug that's called axitinib that you have seen, unlike we saw with the previous target agents where we didn't really see significant tumor shrinkage of primary tumors in the kidneys, with this second-generation tyrosine kinase inhibitor, as we call them now, you have seen more than you would have expected with significant shrinkage in maybe 2/3 or 3/4 of the patients. So I think the jury is still out. I don't think we can say that these drugs don't work in the adjuvant setting. The trials are out, and we will have the results in the next 2 or 3 years, at least with the first trial, the largest trial, the ASSURE trial. We will see if these drugs do have value in the earlier stage disease than in the advanced stage disease. But, this concept of drugs working in the metastatic setting, not working in the earlier stage setting, is not just in kidney cancer. In prostate cancer, for example, chemotherapy works very well for patients with advanced castration-resistant prostate cancer, but when you give them early on, when the patient still has disease in the prostate, they don't work. So that is a concept that is not just for kidney cancer, for many genitourinary cancers.
And I think the point needs to be made that these drugs target the vasculature. They're not anti-tumoral. They don't attack the cancer cell. They attack the blood vessel that supports the cancer cell. And in the setting of micrometastatic disease, do we even know if these cancer cells have a vasculature? So it may not have any impact on them at all. All right, let's move on. 59-year-old Hispanic male who presents with abdominal pain, has hypercholesterolemia, so relatively healthy. Has had left foot surgery in the past. CT scan of the chest is normal. Labs are within normal limits. And you can see here in the lower part of the right kidney, there is a mass. Let's see, Dr. Karam, what would you recommend for this patient?
So I would discuss all the options you've listed here, but if the patient wants active treatment, I would recommend a partial nephrectomy.
How would you do it? Open, robotic?
Looks in good position to do it robotically for me, so I would offer it as a robotic operation.
Dr. Arar, do you want to comment on ablation in this setting and some of the concerns you might have regarding ablating this tumor?
So every time you look at a tumor in the lower pole of the kidney medially, you look at the ureter. But in this case, I see the ureter, the tube that kind of collects the urine from the kidney all the way to the bladder, is far away from where I would be ablating. So I'm not worried about it. I have to say, in this day and age, even after 10 years of experience, ablation is still not generally accepted as first-line therapy. So partial nephrectomy for a patient 60 years old with another 20, 30 years life expectancy, I think it's the way to go. If they're healthy enough to undergo a partial nephrectomy, I think I would advise them of that. But there are certain patients that absolutely don't want to have surgery, and we've seen that also. And it comes to the patient's wishes ultimately.
Anyone else, any other comments on this?
I mean, the struggle with ablating a younger patient comes with the discrepancies in follow-up, and how do you know that you've completely ablated all of the tumor, and how long do you follow these patients? And there's, depending upon what if you use cryotherapy or you use RFA, there's some discrepancies in literature regarding whether or not a negative CT scan or negative MRI actually means, and what that does mean. So when you're talking about a younger patient, I think we tend to be more along the lines, as Cameron just said, more along the lines of surgery. But I would say one other thing. I would not talk to the patient about number 4. It's clear that if you have a small renal mass, and we talked about the nephrometry score before, so if you go back to this mass, go back to the picture, this mass is in an easy location surgically to remove. If you have a mass like this and you're told you need to have your whole kidney removed, I think today that is a wrong answer. You should not have the entire kidney removed, just part of the kidney. Should have a partial nephrectomy here if you're going to have active treatment. And the reason for that is long term, this patient has hypercholesterolemia, but in 10 years, this patient may have atherosclerotic disease, may have other factors which may predispose the patient to having underlying kidney disease. And saving as many nephrons or as much normal kidney as you can actually appears to provide a survival benefit independent of the benefit we're giving the patient by treating their cancer. So being off of dialysis and not having chronic kidney disease, you live longer. So partial nephrectomy would be standard here.
Can I quickly comment?
Quickly.
So I disagree with you on one point. I would mention it's an option, and I would mention specifically it's an option that should not be done. Maybe the patient's coming to you just for a second opinion and they're going somewhere else to get treatment. So at least you should tell them it is an option, but it's an option that should not be done.
All right, you guys are talking too much. We're going to get moving on. All right, 53-year-old black female presents with chest pain, shortness of breath, previous history of diabetes and glaucoma, never had surgery, takes metformin, CT of the chest, no pulmonary nodules, MRI of the brain bone scan is negative. She's got a BNP of 141. That just measures heart strain, and she's slightly anemic. And you can see from her CT of the chest, these black areas right here are sitting in the pulmonary artery, leaving the heart. So she's had massive bilateral pulmonary emboli, and that's why she's short of breath and has chest pain. And you can see she has a locally advanced tumor involving her left kidney with a tumor thrombus that extends into the vena cava and up the vena cava. You can see here the tumor thrombus sitting inside the vena cava right here. Here's the locally advanced tumor involving the left kidney. Let's see. Dr. Mateen, what would you recommend to this patient? And these are just guides. You don't have to necessarily pick one if you don't want to.
So I mean, you're left to wonder whether the pulmonary emboli are from the tumor that's broken off, or whether they're just what we call a bland thrombus, meaning just blood clot. If she's a candidate for surgery, I would just proceed with a left radical nephrectomy and IVC thrombectomy for the time being and observe her, assuming she's doing well from a cardiopulmonary perspective.
Well, that raises the issue. How long would you wait before doing that? She's short of breath sitting there. She's panting.
Yeah. So, we anticoagulate on the assumption that it's a bland thrombus, do scans of her legs and upper extremities because the clot could have come from there. Assuming that's all negative, you wait about, I think the safety time is about a month on anticoagulation, and then after that. But obviously it just depends also on how well she's breathing at that
Dr.
point.
Karam, you got any thoughts on this?
I would agree with Dr. Mateen, as initially I would start anticoagulation, get the patient to be less symptomatic, so she needs to be breathing better before she undergoes a major operation. But I would repeat the imaging right before surgery to make sure that the thrombus hasn't progressed, just because it might change surgical planning, or who other from your colleagues you need to involve, such as vascular surgeons or whatnot.
So how long would you wait?
At least 2 weeks, probably 2 to 6. There is no magical number, but at least I want to make sure the patient is less symptomatic or feeling better before we proceed.
Well, what's your magical number?
4 weeks.
4 weeks. But she says, doctor, I have cancer. Won't it spread?
I would explain to the patient that it might in that 4 weeks, but that the more acute, life-threatening event is the pulmonary embolus or the blood clot in the lungs on both sides. So that's the more dangerous, immediate threat.
Any role to send her to Michael sitting on your left there for targeted therapy to keep this thing under control while she's getting better from her pulmonary emboli? Michael, you want to comment on that?
I would say no. I mean, there's, again, we've talked about kind of neoadjuvant and adjuvant, and this would be, I guess, neoadjuvant, but there's really no role for using a targeted therapy in this setting. We don't have great data with how the targeted therapies work when the tumor's intravascular, but I mean, certainly she's very sick and has other problems we need to address.
Yeah, and it's not uncommon in my practice. I'll get patients from the outside that have an IVC thrombus, and they're started on targeted agents by their oncologists, well-meaning oncologists in the community who tell them basically this will keep it under control, this will shrink the thrombus, this will make your surgery easier. And the vast majority of cases, and perhaps Dr. Delacroix actually did a research project on this, in the vast majority of cases they're wrong.
I'm seeing this now that I'm back in New Orleans. I'm seeing people who are trying to downstage patients with IVC is the inferior vena cava, biggest vein in your body, and these tumors that are in the kidney sometimes can grow into the vasculature and sort of be free-floating, sitting in the inferior vena cava, which goes all the way to the heart. Sometimes these tumor thrombosis can go all the way to the heart. So it's a big surgery depending upon if they're all the way up in the heart. It can require chest to be open as well as the abdomen and patients to go on bypass. And it requires a surgical team with not only a urologic oncologist, but a lot of times with a cardiac surgeon. So I see people that put patients on targeted therapy in the hopes that the tumor will shrink and the tumor thrombus will shrink and make the surgery less extensive. But when we looked at our institution here as well as from Dallas, we looked at all the patients who had tumor thrombus and were started on targeted therapy. Now, these were all metastatic patients. And more commonly, the tumor thrombus actually grew in size rather than shrinking. So this female has no evidence of metastatic disease. She needs to go to the operating room and be cured, attempted to cure with a knife.
Well, I guess that my only caveat to that, I wouldn't say no evidence of metastatic disease. We really don't know what these tumor thrombi are. What about embolectomy? Any role for that? Would you go after these pulmonary emboli?
That's where you put the surgery team together. That's beyond our expertise. I'd talk to the vascular surgeon.
Now, you've done that, right? Not you alone, but you with the cardiac surgeon?
Embolectomy?
Yeah. And in what case was that?
That was an acute embolus. These chronic, so these, she embolized and has gone many days with these emboli. She's actually lucky she's not dead. I mean, she had bilateral saddle emboli. She's lucky to be walking. There's really no role for embolectomy. They're really, at this point, socked in and scarred in. You'd have to do bilateral pneumonectomies to get them out. All right, 83-year-old presents with vague abdominal complaints. He's got a few medical problems: hypertension, atrial fibrillation, coronary artery disease, status post stent ×2, peptic ulcer disease. He's had a AAA repair, so abdominal aortic aneurysm repair. Takes Lipitor, takes Flomax for his prostate, takes Plavix and aspirin for his stents. These are blood thinners. Labetalol is a beta blocker. Amiodarone is for his heart, and gabapentin. CT chest negative, labs within normal limits. And he has this mass present here in the left kidney. And this is another view. This is at the very lower pole of the left kidney. Dr. Mateen, what would you recommend to this patient?
So how big is the mass now? It's about 3,
About
2.5
centimeters, 3.3 to 3.5 centimeters.
Yeah, so not an ideal situation for surveillance. He's not that unusual of a patient that we see these days in terms of medical illnesses. It's not to say they're minimal, they're pretty significant, but it's nothing that we don't deal with. He'd need to go off Plavix for a while, but the option would be ablation. We do a biopsy. If he was going to do ablation, make sure it's kidney cancer, and if it is, we would ablate. assuming it was safe to do because the colon's kind of close. Alternatively, a partial nephrectomy, which I would consider doing robotically.
After AAA?
Yeah,
Really?
yeah. As long as there weren't any problems intraoperatively, it's generally not too much of an issue.
Dr. Chapin?
So I'm assuming that the stent's replaced a while back.
8 months.
Okay. Yeah, I mean, I think Dr. Mateen covered it all. You could do a active surveillance with or without a biopsy. I mean, taking this patient who has stents now for 8 months off Plavix and potentially off aspirin for a biopsy is not a benign thing to do either, because they have to be off for a period of time, and I don't know how long Dr. Rao would have them stay off after the procedure, but they'd be off Plavix and aspirin for at least 5 days prior, which puts them at risk for cardiac problems as well. Partial nephrectomy, I mean, I wouldn't attempt this through a lap or a robotic approach. I would do this through a flank incision if that was the direction that we were headed. But given his age and comorbidities, I would probably recommend initially active surveillance and then ablation if he wanted active therapy.
Cameron, what do you think about ablating this thing?
As Sereno mentioned, it's pretty close to the colon, but we have techniques that we can apply in terms of injecting fluids inside the peritoneal cavity, separating the colon and creating a safe buffer to create the zone of ablation that we're looking for. So technically it's feasible, would be a little bit more difficult. The beauty of percutaneous ablation is that we would have to stop the aspirin and Plavix, the anticoagulation, antiplatelet agents, for about 5 days. But normally we would have started the day after the procedure. And the majority of patients that undergo ablations stay in the hospital for an overnight stay, and they go home the next day. The recovery from the ablation would be pretty quick. Most patients are back to normal daily activities within a day, maybe 2 or 3 days for older individuals.
Do you make a choice about cryo versus RFA based on a patient being on blood thinners? Does that influence your decision?
Yes, I think the data that's out there suggests that with cryoablation, there is increased risk of bleeding and hemorrhage. So I would probably err on the side of doing RF ablation because the heat itself has a cauterizing effect within the tumor and the adjacent blood vessels. That would be a pertinent point.
All right, let's do one more and then we'll take a break. 57-year-old presents with cough and lower extremity edema. No urologic complaints. Lab work indicates hypercalcemia and anemia. Imaging is obtained. They have a performance status of 1, and for the audience that means that they have symptoms related to their tumor, but they're still able to carry on their daily activities. They have a past medical history for myasthenia gravis, gastroesophageal reflux disease, and interestingly, ADHD, and have a past surgical history of a C-section ×3, and they had a thymectomy for their myasthenia gravis. Just real quickly, Nizar, hypercalcemia, how do you treat it?
So the first thing is hydration. And obviously you want to check their kidney function. You can treat them with bisphosphonates if the kidney function is normal. I assume that this patient's hypercalcemia is related to the underlying malignancy, renal cell carcinoma here in this case, rather than say hyperparathyroidism or some other reasons for hypercalcemia. So these are two, we refer to them as poor risk features. When you see low blood in the patients and hypercalcemia, these are adverse factors that are associated with a guarded prognosis.
So here you see a locally advanced tumor involving the right kidney, a tumor thrombus extending into the renal vein, and then extending into the vena cava here. And on this coronal view, you can see that the tumor thrombus extends up into the portion of the vena cava that's surrounded by the liver, and also extends a little bit inferiorly. So we have a locally advanced tumor involving the right kidney with an inferior vena cava thrombus that extends up to the retrohepatic vena cava, and also has a history of anemia and hypercalcemia. Dr. Delacroix, how would you approach this patient?
He has no evidence of metastatic disease.
CT chest and bone scan and MRI of the brain are all negative.
Then we'll medically optimize him.
It's actually a sheet.
Say again?
She?
She.
C-section times 3.
Okay, gotcha. So we'll medically optimize her, and we'd take her to surgery for a open right radical nephrectomy with IVC thrombectomy. If she had significant metastatic disease, and she's got elevated calcium, anemia, those would be poor prognostic factors, but in the setting of having no metastatic disease, upfront surgical resection here.
Okay. Anyone disagree with that? Any role for targeted therapy beforehand, Nazar?
I think since the performance status here is 1 and there is no metastasis, and assuming you say this is surgically resectable, including the thrombus, once the calcium, serum calcium is controlled, the hypercalcium is controlled, I favor going with surgery up front.
Okay.
How worried are you about the cough?
I'm sorry?
Does the cough presume to be maybe from the mass pushing up on the diaphragm?
I mean, the cough is presumed to be, we don't know. I think all you can do in a setting like this is, evaluate for metastatic disease, and in the absence, proceed with surgery, but certainly the cough is concerning, as are the anemia and hypercalcemia.
I think the cough is, in this lady, is related to the primary tumor. These large tumors, that's the reason it's causing the anemia and the hypercalcemia. These are called cytokines that are released by the tumors. And these cytokines cause cough, cause the anemia, cause the hypercalcemia. So I think frequently, often when we remove the tumor, the cough goes away. So it's not due to metastasis to the lungs. The cough is related to the actual release of bad things from the tumor.
All right, so the patient undergoes a right radical nephrectomy with IVC thrombectomy and retroperitoneal lymph node dissection. And the pathology reveals T3B, and all that means is that the tumor went into the vena cava. We knew that before surgery. T3B, N0, no MX. So N0 means the nodes are not involved. MX means no evidence, clinical evidence of metastatic disease. But there's greater than 95% sarcomatoid and rhabdoid dedifferentiation. The tumor was invading into the renal vein and the artery wall at the margin of resection. So, Jose, maybe you can explain to me what sarcomatoid and rhabdoid means.
So as we mentioned earlier, the most common type of kidney cancer is the clear cell. There's also the papillary and the chromophobe. These are the 3 more common ones. Sometimes each one of these 3 subtypes can have features called sarcomatoid or rhabdoid. So clear cell can have those potentially. Papillary can have them, or chromophobe can have them. They're not a separate type of kidney cancer. The sarcomatoid and the rhabdoid features, the cells look extremely abnormal. They don't look like normal kidney cancer, and what they mean is that this tumor is extremely aggressive, and the prognosis is not good for patients who have sarcomatoid or rhabdoid, even if they don't have spread or metastasis yet. So this is a very bad tumor, especially that it's invading the artery wall, which is not very common, but not too surprising when you have sarcomatoid or rhabdoid.
So, Dr. Chapin, what would be your recommendations after surgery? How would you follow this patient? Would you recommend any additional treatment? What about radiation? Any role for radiation here?
Well, no. There's no role for radiation in the treatment of locally advanced kidney cancer. I mean, we do have positive margin at the renal vein wall, but there's not much you can do about that other than watch it at this time. I mean, going back and trying to do re-resection of a wall, which would be far too aggressive and probably not yield very much and cause too much difficulty and complication risk. So, I mean, this patient would basically get a 6-week CAT scan in my office, chest, abdomen, pelvis, assess for distant metastases, assess for the local recurrence, and what you see with rhabdoid and sarcomatoid dedifferentiation is you actually can have local recurrences within that short time frame. And then if they did have recurrent disease, either distantly or locally, then the consideration would be to have them evaluated by Dr. Tanier for possibility of systemic therapy at that time.
Nazar, any role for adjuvant therapy here?
Well, I think I was going to say you would consider this patient for an adjuvant trial, except that she has positive margins, so that excludes her from the current adjuvant trials. I think, a comment I'd like to make about the distinction between sarcomatoid and rhabdoid. Rhabdoid does not mean sarcomatoid. Rhabdoid, all it means, it's a high-grade, firm nuclear grade 4 tumor, which portends aggressive behavior. But sarcomatoid actually, I think, is even more worse in the aggressive behavior, and this means that there are spindle cells, spindly-looking cells that look like sarcoma, and that portends aggressive behavior. So there is that distinction, and having sarcomatoid more than 20% in the primary tumor carries an aggressive behavior compared if it was less than the 20%. It's an arbitrary, but I think we all now agree that more than 20% is more aggressive. So absent of a clinical trial, I would observe this patient. I agree that she's at high risk of having recurrence. I was going to say the artery wall invasion may make her T3C rather than T3B, right?
Actually, you're right, yeah.
So she will be followed very closely, and at the earliest sign of recurrence, we will treat her with systemic therapy.
How often, define very closely, how often would you get scans?
I would say I would definitely repeat the scans in 3 months in this lady.
So get them at 6 weeks, and then get them every 3 months?
Every 3 months the first year,
Okay.
I would.
Everyone agree with that, or anyone have a differing opinion? Dr. Mateen, the minimalist, you would do that too?
No, I think I completely agree. I mean, it's appropriate for the risk of disease that's there. I think that's totally on the spot.
Okay, well, my phone says it's 10:35, so we have time for a break, and then we'll reconvene and do some more cases at 11 o'clock. Okay? Thank you, guys.
Test, mic test.
Yeah, no, I remember.
How you doing?
Great, good to see you.
You know, I thought you were talking about my wife and how you.
I've been so far positive feedback.
You're going to have people answer those questions?
Yeah.
Do they have questions?
They have them. All right, we're going to go ahead and get started again. Do some more cases this is again in the locally advanced setting, and then this afternoon will be devoted entirely to cases about patients with metastatic disease to cover the spectrum. So this next patient is a 78-year-old white female who presents with an incidental renal mass. She has a history of breast cancer, and it was discovered during surveillance for her breast cancer. She does have some medical problems: hypertension, diabetes, hypothyroidism, atrial fibrillation, a history of depression. She takes aspirin, diltiazem, metformin for diabetes, thyroid replacement, Diovan for blood pressure, Effexor for her depression. Her metastatic evaluation is negative. Her labs are within normal limits, except for her GFR, which is measured to be 50 cc's. Now, normal GFR for someone with 2 normal kidneys, male, is about 100 to 120. So she's got compromised renal function and would be classified as having chronic kidney disease. She's got a mass sitting right here in her right kidney. Dr. Mateen, how would you evaluate and manage this patient, and why?
Can you go back to the previous slide for a minute? I was busy sipping my coffee. Okay, thanks.
What are you looking for?
No, just the medical history and everything. Yeah, so it's a small mass. Looks like about 2 centimeters roughly.
Mm-hmm.
I would, and the breast cancer is actively being treated now, or just
Breast cancer, she's just taking tamoxifen.
Reasonable to watch it for a while. It's small, and I think that would probably be my primary recommendation for the time being, unless she really did not want to have any more scans and just wanted it treated fully.
So your recommendation would be active surveillance. How often would you follow her? What would you follow her with? And what would be the trigger to intervene?
Thank you. Okay. So if this is the first scan that we have, everybody's worried about maybe it's rapidly growing, and most of them do not, but there are maybe a small percentage that do. So what I do is get another scan in about 3 or 4 months. That's fairly short term, and almost always they're unchanged. And if that's the case, then we get scans every 6 months. I think a CT scan is fine, and it just would be a CT of the abdomen every 6 months. Alternatively, we could do an MRI, but it is harder for the patient, as Cameron was saying, just because you have to lay still on the MRI machine, much more than on a CT. And for older patients, that's harder to do, holding one's breath for 30 seconds or 45 seconds each time. So CT is a little bit easier. What did I say? Every 6 months? Did that answer your questions?
What would be the reason to intervene?
So generally, greater than 0.5 centimeters growth per year is the guideline we use. And then, in addition, over the course of years, it could, of course, keep growing little by little. And if it gets to be 3 centimeters, then we get a little bit more serious about acting on it. The other thing I would talk to her about is the possibility of doing biopsy, and we kind of covered all those issues earlier about that.
Dr. Karam, how would you manage this patient?
I would agree with Dr. Mateen. I would recommend active surveillance as the first treatment option.
Dr. Chapin?
Yeah, I mean, I would agree based on her age and comorbidities. I'm not really sure why she got a CAT scan because they don't do those for follow-up or breast cancer. So presumably she hasn't had any additional imaging before, so we don't really have a starting point, or this happened between the last scan and this scan if there was a last scan. But I would agree active surveillance would be an option, and then I'd give her the option, like we talked about before, of biopsy or not biopsy. A lot of times patients feel very strongly one way or the other, and I just go along with theirs, but I wouldn't necessarily request that they have a biopsy.
She says, Dr. Chapin, I want to do whatever you want to do. What do you want to do?
I would surveil her. I'd follow her up in 3 months with repeat imaging, probably a CAT scan at that time, and if it hasn't changed much, whatever size criteria you want to determine. And Dr. Mateen talks about less than 0.5 centimeters. I mean, if it hasn't grown or it has grown very little, I would still consider watching her, and I probably would image her every 6 months beyond that.
So you'd get a scan 3 months from now?
Correct.
Dr. Arar, what are your thoughts?
Well, I think the AUA guidelines suggested in 2009 when patients present, the urologists are encouraged to give them all the options. A patient like this here would be seen, I'm sure they would be advised that these are the options, essentially a partial nephrectomy versus observation versus thermal ablation. A lot of patients come actually prepared, and they have kind of tendencies towards leaning one way or another. So in this particular patient, considering those 3 options, I think all 3 options are available to her, whatever she wants, and thermal ablation would definitely be an option for her.
So of all the panel members, who would do a biopsy in this lady? 2 for biopsy and everyone else no. All right. Serena, defend it.
Well, I already did. I mean, you don't have to, but I think, a well-informed patient and physician just sort of tends to make a little bit better of a smooth course over time. Truth is, the results will not really alter the immediate plan, but again, I think we kind of go into it more proactively, and rather than being reactionary down the line. On the other hand, actually, it could make a difference if we biopsied it and it showed oncocytoma or oncocytic cells even. We would be even less concerned in terms of its potential to harm her long term.
So this is not an uncommon problem that we see in the clinic every day, where you have an older patient, comorbidities, they have a tumor, and the $64,000 question is, are they going to die with this thing or of this thing? And in the overwhelming majority of cases, they're probably going to die with it rather than of it. And it becomes a struggle as to how intensive our intervention needs to be. And there are other issues that are involved. Some people are very cancer phobic, and the idea of harboring a cancer and just walking around with it is very uncomfortable for them. So we struggle against these issues all the time. So the biopsy was obtained at the time that it was ablated, and the patient did undergo ablation, and the biopsy showed it to be a benign oncocytoma, although they did not know that, obviously, at the time they did the ablation. All right, so here's a 63-year-old white male who presents with abdominal pain, history of hypertension, and coronary artery disease, status post-bypass back in 2001, 4-vessel bypass. These are the medications: atenolol beta blocker, lovastatin for cholesterol, lisinopril for blood pressure, and an aspirin. CT chest and labs are within normal limits.
Dr. Wood, just before we continue, it may be confusing for some of the people that the biopsy showed oncocytoma, but the lesion was still treated. And I just wanted, I know that we do it. Some of you tend to do a biopsy separate from the time of ablation. Others have a patient get biopsied prior to ablation. And whether or not the biopsy is being done for active surveillance or for diagnostic purposes prior to treatment can sometimes change how things occur. So had the biopsy been done prior to thermal ablation may not have been completed.
That's correct. And that's the challenge, and that's something else that we struggle with patients here, particularly at MD Anderson, because patients usually come from far away. And so to tell them to come here, have a biopsy, wait 3 days to get a result, and then have a subsequent procedure, obviously they want to economize their time and minimize the amount of hotel bills and so forth. And so to accommodate that, many times we'll do the biopsy and then do the procedure, but in this case, this patient probably could have gotten by without a procedure. All right, so good point, Brian. Bypass times 4, CT chest negative, labs within normal limits. Here's the tumor. Here's another view. Dr. Karam, what do you think?
Discuss all the options and recommend partial nephrectomy.
How would you do it? Open, robotic, what?
This one I would do it robotic, just based on the location and the size of the tumor. It's small enough and peripheral enough in the kidney to do it.
Would you biopsy it all?
No.
Okay, Dr. Mateen, thoughts?
No, I agree. I think it's a robotic partial would be fine.
Cameron, what do you think about ablating it?
I think it's doable. It's on the larger size. I would probably put calipers on it and measure it carefully. But it's exophytic, which means that it doesn't involve the central portion of the kidney. So tumors that are more exophytic or grow out of the kidney are easier to treat. It's surrounded by intra-abdominal fat. There's nothing around it. So technically it's feasible.
Does tumor size influence your choice of RFA versus cryo?
Yes, it does. In fact, larger tumors there's a cutoff for the RFA. RFA is very effective up until 3.6, 3.7 centimeters. A good study showed that once you go 1 centimeter beyond 3.6 centimeter, then you have, by a factor of 2, you reduce your effectiveness. So all of a sudden, your effectiveness drops significantly. So people have tried cryoablation. And yes, you can create a very large ice ball, but it does require placing multiple cryoprobes and being very aggressive. And that also increases the risk of bleeding. The group at Mayo Clinic treats tumors that are as large as 7 or 8 centimeters. I think all of those patients really should go to surgery, but I guess if surgery is not an option. The largest we have treated probably about 5 or 6 centimeters. There are other adjuvant things we can do to enhance the ablation. We can actually get inside the kidney through an angiography approach and block some of the blood supply to the tumor. And actually that creates a kind of a blood deficient area, if you will, a hypovascular zone where the ablation is actually more effective. So yes, larger tumors can be treated if needed, but obviously if the patient is a surgical candidate, surgery would be a better option.
So this patient underwent a right partial nephrectomy with intraoperative ultrasound. Final pathology reveals a right renal mass, renal cell carcinoma, nuclear grade 2, 4 centimeters in diameter, confined to the kidney, margin of 1 millimeter. Dr. Delacroix, the margin of 1 millimeter, that sounds really close. Is that a problem?
This is renal cancer. We're not breast cancer. The 1 millimeter, yes, it is close, but it really has no clinical implications. I treat this as a negative margin. Nothing different.
Yeah, so the message is, again, in trying to spare nephrons, any margin is a good margin as long as it's a negative margin. So this patient comes back for first-year evaluation. Chest X-ray, CT abdomen are negative. The patient develops recurrent right flank pain, gross hematuria, in September of 2012, so 2 years after surgery. The meds haven't really changed, no interval change in past medical history. And here's the scan. So you can see here's the right renal remnant, and there's this rather large tumor hanging off the right renal remnant, extending to the body wall, and may or may not be involving the retroperitoneal musculature as well as the rib. Here's another view. Again, you can see lots of postoperative change, potential extension to the sidewall here, but definitely a recurrent tumor present in the right kidney. And if you go back, it's kind of where the old tumor was, but perhaps maybe a new tumor. Hard to say.
What was his
And the
initial
patient now had, I'm sorry?
What was his initial surgery? What did y'all do?
What did we do?
It was an open partial?
Yeah.
Okay.
So the patient presents now with this, and then on CT scan, we see a nodule in the right lung, as well as some nodules in the left lung. So, patient had a localized tumor, 4 centimeters, resected, has a sort of what looks like an aggressive recurrence with pulmonary nodules. Dr. Karam, how would you approach this patient?
So I assume this patient has good performance status, and except for the gross hematuria.
Correct.
I would offer the patient surgery. Number one, he has the bulk of the disease or the cancer is in the kidney and the abdomen area, so I would resect all of that aggressively. And the bulk of the disease is there, so that's where we should go. And the other thing is the patient is symptomatic. The patient has bleeding in the urine, and surgery will take care of that as well. And then give the patient a break, and then refer him to our colleagues with medical oncology to offer him therapy.
Any role for biopsy here? Biopsy of the primary tumor or biopsy of one of the lung nodules?
No, I think it would be safe to presume it's the same type of tumor, and even if it's not, the patient's still symptomatic and good performance status and has a problem in that kidney that needs to go away. So I would not biopsy the patient.
All right, you refer the patient to Dr. Tanier prior to surgery. Dr. Tanier, how would you counsel this patient?
I agree with Dr. Karam. I would go with surgery up front for the reasons Dr. Karam mentioned. The bulk of the disease is in the kidney or the remnant of the right kidney. The patient is symptomatic, is bleeding. I would do surgery first.
Michael, any difference from that? Would you recommend surgery?
I would recommend surgery. And I guess, we're kind of alluding to the fact that there's not a lot of data for cytoreductive nephrectomy. In our current era, there were 2 trials that had virtually identical inclusion criteria in the so-called cytokine era that showed a benefit in terms of overall survival for cytoreductive nephrectomy. We're presuming that there's that benefit now, although there will be several trials, Carmina included, that may answer that question. And then in addition, as far as our new targeted therapies go, most of the patients in those studies, so 80-90%, had cytoreductive nephrectomy or nephrectomy one way or another. So we're presuming there's a benefit.
I think for the people in the audience, we've all of a sudden introduced this new word, cytoreductive. We should just clarify. Everything you've seen up to this point has been renal masses without disease that has spread somewhere else. Cytoreductive nephrectomy is when you have a very good idea and you can see disease that's spread elsewhere. Should we be treating the primary tumor? And that's what we're discussing here.
Thank you.
Just letting them know.
So the patient undergoes cytoreductive nephrectomy. It's clear cell histology T3A. Patient returns in follow-up 6 weeks later, has same pulmonary nodules that have slightly increased in size. Michael, what are you going to counsel this patient? What are you going to recommend?
So I was trying to remember the patient's comorbidities and things like that, but I think depending on the patient's comorbidities,
Hypertension and coronary artery disease, status post bypass.
Yeah, so we're always thinking whether high-dose interleukin-2 is an option. Probably based on the patient's history, I would be concerned that patient could tolerate the different fluid shifts associated with that. If the patient were motivated, we could pursue further workup, including cardiac echoes and pulmonary function tests and things. Again, we're assuming we've removed the bulk of the patient's disease in the kidney, and there are only several small bilateral pulmonary nodules. I think most likely, though, the case is going to be either number 2 or number 4, thinking about our VEGF receptor TKIs, sunitinib or pazopanib, or certainly clinical trial. This is probably a good or intermediate risk patient, and that would be level 1 evidence or standard of care.
Did you do the nephrectomy through the previous flank incision, or did you go through an abdominal incision?
Abdominal incision.
And was it involving the rib or no?
Dr. Tanier, what are your thoughts?
I agree with Michael. The patient is not a candidate for high-dose IL-2 because of coronary heart disease and bypass. He's at risk of having cardiac arrhythmias and potentially fatal complication from that. So the options would be target therapy. I prefer participation in a clinical trial. It depends on the patient, where the patient lives, and if the patient is going to be followed at MD Anderson or followed up locally. I think it's always more convenient for a patient to take an oral agent. So while bevacizumab plus interferon is an option based on level 1 evidence similar to sunitinib and pazopanib, I think you're giving the patient 2 parenteral agents, one IV bevacizumab and the other one is interferon injections. So the inconvenience, the cost of that would make me, if the patient is not interested in clinical trial or cannot come here, then I think sunitinib or pazopanib would be the 2 options. Which of the 2? I think they're comparable in efficacy. I think one would look at the patient's liver function tests, history of any liver disease, where the risk of pazopanib having liver toxicity will be higher, then that will sway me towards giving them sunitinib. And then if, again, the patient wants to follow up locally, I think it's always important for the patient and for our professional relationship with our colleagues who refer patients here is to discuss the patient with the local oncologist. If the local oncologist is comfortable using sunitinib, then I think sunitinib would be fine. If they prefer to use pazopanib, then I think pazopanib is fine.
So are the 2 equivalent, essentially?
I think in terms of efficacy, there is a trial that was presented last year in Europe, the COMPARES trial, looking at both agents in a phase 3 trial that included 1,100 patients. The efficacy was comparable. So that trial was designed with a primary endpoint non-inferiority based on progression-free survival, which means the time from initiation of therapy until there is disease progression or death. The 2 arms, the 2 drugs produced basically similar or comparable results. In terms of toxicity, I think each drug has its own adverse events. Sunitinib, for those patients of you who have taken it, is associated with more fatigue than pazopanib overall. Pazopanib, as I said, is associated with more liver toxicity. I think they both produce about the same in diarrhea, although sunitinib causes more hand-foot reaction, skin reaction, which is the blisters, calluses on the hands and feet. But I think sunitinib has been on the market longer, so it was approved in January 2006, so 7+ years. I think there are patients who are survivors past 5 years on sunitinib. I think the follow-up with pazopanib is shorter, so I think that should also be taken into account. So it remains to be seen whether 5 years from now the 2 drugs produce the same fraction of patients who are alive, past 5 years. But for all practical purposes, I think they're comparable in their efficacy.
Okay. All right, let's move on. 50-year-old white male presents with right-sided flank pain, no urologic symptoms, excellent performance status, CT chest, MRI of the brain, and bone scan are negative, and a biopsy of this primary tumor here reveals it to be clear cell renal cell carcinoma. What are your thoughts? Dr. Chapin?
Do we have any other imaging workup, or is this?
Nope, that's it. So you got a locally advanced tumor clearly involving the renal sinus and collecting system of the left kidney extending very centrally.
Yeah.
No evidence of any metastatic disease.
So I think in this setting, here we try to go to a clinical trial first if one's available. In the absence of a clinical trial, I would offer this patient a left laparoscopic nephrectomy. And based on your imaging, I mean, you're telling me it's invasive of the renal sinus there in a single image. Taking your word for it for T3 disease, I would do a lymph node dissection with my nephrectomy.
So laparoscopic radical nephrectomy with a lymph node dissection.
Yes.
Dr. Karam, your thoughts?
I think that's a reasonable option, but like Dr. Chapin asked for more images just to make sure how resectable the tumor is. I mean, another option would be to do a partial nephrectomy, especially if the patient does not have good kidney function, which just another consideration. And sometimes I tell the patient we will try to do a partial nephrectomy, but there is a high risk of ending up with a radical nephrectomy. But the only downside to that, or the main downside, is that we will have to do it open, or I would do an open partial if I can, converting it to a radical through the open incision if I cannot achieve good margins.
Dr. Delacroix?
I would offer this patient an open, attempted left partial. Again,
What do you think the odds of success are?
I don't have all the images here.
Can you stop whining? You guys are
I know.
whining.
I know. Probably, I'd tell them 40, 50% chance I'm going to have to take out the kidney.
Tumor goes almost to the other side of the
Yeah,
sinus.
yeah. I mean, but I look at this image down here. Really, this is one where you need more images. But if I look at the images and I think if I have a 50% chance that I can do a partial nephrectomy, that'd be what I did.
This picture almost begs the question if this is the same tumor or not. It looks so nicely encapsulated on the right side, and it just looks much different on the left-sided image.
It's a lobulated tumor that extends centrally. This cut over here is lower.
I would have chosen some better pictures.
Oh,
So can I ask Chris?
Yeah.
Why you're presenting all these patients who have pain that doesn't really is not explained by their tumors? Right-sided flank pain. Here is the tumor on the left. The other several patients had abdominal pain or left flank pain, and the tumor is on the right. What's going on here?
I mean, it's a very common presentation. They present with symptoms that are completely unrelated to their renal tumor, often contralateral, and yet they have these findings. I mean, these are all real patients, all real history and physicals.
Well, it's also the CAT scan when you walk into an emergency room.
Exactly.
I mean, people have back pain, people have flank pain, people have history of kidney stones. Any trigger gets a CAT scan now when you walk in the ER. Not that it's correct, and most times it's not, but that's what happens, and then they show up in our office with this history.
So not to belabor the point, but basically this patient was enrolled in our neoadjuvant axitinib trial and received 3 months of neoadjuvant axitinib. Axitinib is the new targeted agent from Pfizer, escalated to 10 milligrams BID. It was relatively well tolerated. Grade 2 hypertension and fatigue, hypothyroidism, and stomatitis. And these are the follow-up images. I trust these images are adequate for your use?
Those are adequate, and that definitely appears to be a much easier partial nephrectomy. You could even attempt that robotically.
So you can see that the tumors regress dramatically, and plus also, in addition to shrinking in size, there's this central necrosis where the inside of the tumor is basically dead, and that's related to the anti-angiogenic effect of the medicine to cause the blood vessels to regress. And this patient underwent a partial nephrectomy with intraoperative ultrasound, and it turned out to be a T1A, from grade 3, so shrank the tumor dramatically. And this may be the wave of the future. I think neoadjuvant therapy, particularly with these new targeted agents, may be the wave of the future to try and decrease the size of the primary tumor to either make surgery easier, make nephron sparing more feasible. But obviously, all of this needs to be studied in the context of a clinical trial.
I think that's very important. Just go ahead.
Can I just ask a
Same
question,
thing,
Dr.
sure.
Mateen and Dr. Wood? What have you found intraoperatively? Do you find that the tissue planes are any different, especially robotically, after targeted therapy? Or
I think that you can get this rind, reactive rind around it. Other than that, it's I'm not sure it's that much more difficult.
Yeah, I haven't noticed any dramatic changes. I mean, which is actually very fortunate. You'd expect many times, like for instance, with testicular cancer patients after getting chemotherapy, there can be this tremendous reaction around what's left over because of the dying tumor and your body's immune system attacking it. And that was a concern here. Could this actually make the surgery harder? But that has not been our experience. And in many patients where it was either a borderline partial or partial was not possible, we were able to shrink the tumor using this drug and perform partial nephrectomy with good outcomes.
I would just want to stress the importance that this is on a clinical trial basis, and that this would not be considered something that would be standard. And we've made point of that several times today of not giving TKIs with the hope of downsizing or downstaging a tumor. Although we see a lot of anecdotal cases in the literature, and I think that it tends to falsify kind of what people think of this. Mm-hmm. I know your experience so far with axitinib has been different, and when that's published, it can be something that we evaluate further. But at this point, this is only in the context of a clinical trial and would not have been standard of care therapy.
Okay. I'm going to just pause for a second. Right now at 11:30, we're supposed to have questions and discussions. I'm going to continue to present cases, but if you all have questions, by all means, get up, come to the microphone. We can stop and answer any questions that you have, okay? So 51-year-old comes with a left flank pain and blood in the urine, good performance status, slightly anemic, but otherwise labs are within normal limits. CT chest is negative, and the patient is offered a laparoscopic radical nephrectomy. Here are the images. You can see a locally advanced tumor involving the left kidney. There's maybe some shoddy lymph nodes present here and here. Locally advanced tumor involving the left kidney, no metastatic disease. Dr. Mateen, what are your thoughts?
Yeah, I mean, I think that's fine. The best answer is to basically do whatever you're most comfortable with in terms of giving the patient the best cancer outcome. If you have the experience laparoscopically to do that and as well sample those lymph nodes, then you should. If you're uncomfortable, then either refer them or do it open.
And so what would you do?
Oh, I'd do a laparoscopic nephrectomy and do a lymphadenectomy.
And when you do a laparoscopic lymph node dissection, are you able to get to the interaortic cava nodes, which are the nodes between the aorta and the vena cava?
Yeah, we can. Now, whether that actually makes a difference or not for a patient like this is still a question. Mm-hmm. I would, at the very least, do the ones between the aorta and the kidney. There's talk about doing a frozen section, seeing if there's disease there, and then doing more. I mean, so.
Is that what you do?
No, I don't. I mean, we could discuss it, but I don't. And I'm not sure there's much benefit in going, interaortocaval if there's multiple nodes present.
Dr. Crum, what are your thoughts?
I would do a laparoscopic nephrectomy on the left side and then do the lymph nodes just between the aorta and the kidney. I wouldn't necessarily go between the aorta and the vena cava.
Dr. Chapin?
I'd probably take a little bit of a different approach, and I would actually do a nephrectomy with a extended lymph node dissection to include the interaortocaval nodes. Whether this could be done with a robotic assistance would make me more comfortable for doing interaortocaval with a minimally invasive approach. So I would do a robotic nephrectomy and an extended node dissection to include the interaortocavals.
Robotically?
Correct.
So the patient elected to have their surgery at home in Tennessee, and they underwent a laparoscopic radical nephrectomy. And the pathology, which was reviewed here, showed a renal cell carcinoma 6 centimeters in size, clear cell type with focal sarcomatoid features, 10%, firm and nuclear grade 4, invasive into the renal sinus soft tissue, margins of resection negative, adrenal gland negative, so this would be a T3A, N0, M0, Perman's grade 4, clear cell renal cell carcinoma with negative margins, 10% sarcomatoid.
Is it N0 or NX?
NX. Well, nodes were removed. The nodes that were removed were negative. Dr. Tanier, the patient comes to you in follow-up. What do you tell him?
They're at risk of recurrence because, again, size, the more than 4 centimeter, firm nuclear 4, 10% sarcomatoid features, and as you said, T3A. If there is any clinical trial that they're interested in and they're eligible for it, I would offer them adjuvant trial.
So you'd offer them an adjuvant clinical trial? Okay. And if they're not eligible for the adjuvant trial, how often would you follow this patient?
I would follow the patient with a scan 3 months after surgery, and then another one 6 months later after that.
So every 6 months?
Yeah, twice a year.
Everyone agree, or anyone disagree?
I would follow the patient a bit closer,
Yeah.
although the cutoff for sarcomatoid, Dr. Tanier mentioned the 20% is not an absolute cutoff. This patient is at a very high risk of recurrence, and I would just observe him every 3 to 4 months for at least the first 2 years, just because of their high risk of recurrence. And like Dr. Tanier said, if the patient is eligible for a clinical trial, he should undergo or at least consider an adjuvant clinical trial.
So the patient is observed postoperatively, and he's told to come back in 6 months for repeat imaging. He's asymptomatic. His CT chest remains negative, and he comes back with this. You can see he's got a rather large tumor involving his right kidney that extends really right up into the renal sinus and the renal hilum. 2 views. I trust these are adequate for you, Dr. Delacroix?
Yes.
Okay.
Is that a positive lymph node on the left? Or?
Yes.
Where?
Periaortic?
Periaortic.
No.
On the right picture?
No, that's
No.
Cruz.
That's
All right.
Cruz in the file. So if you go back and look, there was a question of a hint of something sitting right here. I didn't want to point it out to you, but right there. And that was the genesis of, oops, other way. This.
So this would have supported doing closer follow-up.
But this is
Dr. Mateen, what do you think?
So this came back and this grew this much in what, 6 months, 1 year?
6 months.
Wow, yeah, pretty aggressive. I'd make sure he had recent restaging studies
They're all negative.
and book him for a partial.
Book them for a
Not do it
partial.
open, yeah.
And the likelihood of success?
Again, I'd take the Delacroix approach and ask for more images first. But assuming this is the worst that it is here, I think chances of success of actually removing the whole tumor and preserving the kidney, I'd say, are greater than 90%. There would be a
90%?
risk of, what's that?
90%?
Yeah.
I think that's
Yeah, it's difficult, no question.
optimistic.
Yeah, but it's the single kidney, and I think we would give it the best shot we had to preserve the kidney and as well get the whole tumor out. Now, the alternative would be the clinical trial. If there is one available in terms of treating the patient ahead of time in the hopes of getting that to shrink down.
Dr. Karam, what are your thoughts?
I think clinical trial will be my number one choice. I think this will be quite a difficult partial nephrectomy. If the patient is willing to take the risk, then I would go for surgery. By saying risk, I mean the risk of ending with a radical nephrectomy possibly.
And what is that risk?
I would quote the risk being higher than what Dr. Mateen said. I would say, for me, I would say at least 50-50. But again, it depends on surgeon comfort and experience. But I would quote the patient 50-50 chance.
Would he qualify for a neoadjuvant trial having had a previous cancer, even though it was treated?
No.
No.
Dr. Delacroix comes to New Orleans.
Yeah, if I was seeing him in New Orleans, if he didn't qualify for a neoadjuvant trial, then I'd do an open partial on him.
And
If he would qualify for a trial and we'd be willing to travel, I'd tell him to get in his car and come see you for a trial. So that'd be an easy one. What would I quote him?
Yes.
Numbers are. We try to objectify the something that's not quantifiable, but I'd say 50-50.
Yeah, I would definitely counsel the patient on the good possibility he'd wake up without a kidney and on dialysis.
So, and I think this is important for the audience to see. So all of these guys either work together now or at least trained by the same people, and you can see that the variation in in their responses with regards to predicted risk of losing that kidney and so forth. So I personally thought when I saw this guy that he was going to lose his kidney because, this right here, this tumor goes right up to where the vessels are entering into the renal sinus. And I thought that the likelihood of either leaving cancer behind to try and save the kidney or leaving it with no functional renal tissue were quite high. And so I said basically your options are you could undergo a radical nephrectomy, go on dialysis, the possibility of a transplant 2 or 3 years down the line if you remain disease-free, or we could try targeted agents to see if we could get the tumor to shrink. So the patient underwent a biopsy. It showed high-grade clear cell renal cell carcinoma, and he was offered nephrectomy versus pazopanib because the clinical trial, he's not eligible for a clinical trial with axitinib. He decided to choose pazopanib, and he comes back 50 days after treatment with a CT chest that remains negative. And there are the films. And I would argue slightly bit easier to do a partial nephrectomy in that case. You can see the tumor here has shrunk dramatically. It's pulled itself out of the renal sinus and is much more amenable to partial nephrectomy from my perspective. He underwent a right partial nephrectomy, and it was a T1A, N0, M0, Berman's grade 4 with extensive necrosis, so a dramatic response. And, again, admittedly, this is an anecdote, and you could maybe take 10 people, and the other 9 might not respond at all. But I felt that this was this guy's best hope at trying to save his kidney.
Was that the newest TKI available at the time?
No, axitinib was available.
So why did you choose that over Axitinib, given your experience with axitinib?
I take that back. Axitinib was available through a clinical trial mechanism, but it was not FDA approved. Right.
Okay.
Sorry.
And if that had occurred now, you would
Use
choose
axitinib for sure.
based on your experience?
For sure.
Second line,
For sure.
not first line. Would not have been eligible.
Questions? No questions?
His insurance would not have
Yeah.
covered it.
Seems to be a abundance of information about saving that kidney. We have people donate kidneys all the time to help family members or whomever. When you have something that's as serious as those appear to be, layman's foot bottom, whatever, find out how one. Why are we taking the chance of possibly losing the patient totally rather than letting it
And I'm just going to ask, in the future, for future questions, please use the microphone so they can hear you on the YouTube broadcast, but I'll restate what you asked. Basically, you're saying, why not just do the nephrectomy and then get a kidney transplant? Or just end up on dialysis or something?
There are a lot of people running around out there without any kidneys, or only one kidney.
Sure. And well, in this case, if we had done a nephrectomy, he would have been on dialysis. The problem with transplant is in patients with cancer, they are not eligible for transplant unless they're disease-free for at least 2 and some say 3 years, because the immunosuppression associated with transplant, if they had cancer, would let the cancer go berserk. And you know, dialysis is not a cakewalk. I mean, having to go to a place for 3 or 4 hours 3 times a week, and the mortality rate associated with dialysis is 10% per year. So that means that 50% of people are dead on dialysis at 5 years. So that's not exactly a good outcome either.
I know this is a difficult question. How much work is being done right now on cost? We're talking about treatment here. I mean, that's the focus of this. I understand that. The question becomes, this individual had it once. Was there any way of making a determination as to potential causes to help them avoid a recurrence, or in some way looking at either environmental or genetic factors that might contribute to this and trying to treat that in the interim?
I'll let Dr. Karam field that one.
So as far as cause, I'm not aware of much research being actively done to look for a cause. We know there are some known risk factors. I think smoking is the one that most people would agree on. It's a very high risk factor for kidney cancer. There are other causes that are not as certain. I think they're more speculative, such as diabetes or high blood pressure or obesity as potential causes, but the link is not very strong. So we can't tell the patient if you lose weight, you will have less chance of kidney cancer. So these are associations. The main risk factor that we know of for sure are the genetic risk factors. So we know in about 5% of patients, genes play a major role, and this is something that would run in a family. But other than that, for kidney cancer itself, these are the main known risk factors. There are other cancers that happen in the kidney that are not labeled as kidney cancer that we know from environmental factors or from herbs, and Dr. Mateen might comment on that, but that's not kidney cancer itself. It's another subtype.
Let me follow up, because in my situation, I had a radical nephrectomy. Mine, a proximate cause was taking Prozac. I had Prozac, I became allergic to it, which caused vasculitis, which vasculitis is a known cause of renal cell tumors, especially if it goes into the kidney, which mine did. And it was very definite that the Prozac caused the vasculitis because I was off of it, vasculitis went away, went back on it, and within 24 hours, the vasculitis was back full blown. And it was a short period of time after that that the renal cell carcinoma was discovered. And I had been clear before that because I had had some physicals done because of leaving the Army. And I had no indication of renal cell carcinoma at the time. After that, and after my surgery and surviving it, I posted some stories out on the Kidney Cancer website, and I received numerous responses back from all over the world, people with an exact similar situation. I know that no real study had been done as to the relationship between those, or a direct relationship between Prozac and kidney cancer, but the steps that were associated were repeated multiple times, which is why I brought up the question.
Yeah, I mean, it's an interesting thought, and like you said, there is no study yet, but it'll be interesting to gather the data. But the risk with all these studies, even the studies that show that smoking is a risk factor, is that there's a lot of confounding. So let's say if theoretically that drug A causes kidney cancer, but all the patients who took drug A also are smokers, then which one is it really? Is it the drug A that caused it? Is it the smoking? Or is it the combination of both? And there are other cancers where there is some association between drugs that cause them, for example, bladder cancer and a certain diabetes medication. But again, it's hard to tease out which factor because we live in a complex environment. It could be the medication, the water, the smoking, or other risk factors. But it'll be interesting to gather objective data and see if that holds true when we account for the other known risk factors too.
And interestingly, actually, alcohol provides a protective effect. So if you are going to smoke, you might as well drink. Nancy, go ahead. Go ahead, Nancy.
Well, that's good to know.
Except that puts you at risk for oral head and neck cancer. So he's joking, obviously. So.
In the 10 or so cases that you've presented, it's sort of hard for us to tell by looking at that, the size. Sometimes you've mentioned what they are. But there's only been one, maybe two, where neoadjuvant therapy was considered something to do. And I wanted to be sure I understood, were you saying that's only available in a clinical trial setting, or it was only a particular type of neoadjuvant that was available only in a clinical setting? And then why that particular 50-year-old, this is where I was saying it's hard for us to differentiate that 50-year-old, the one before this one. Was there something about that tumor characteristic, or was it the age or something that led you to the neoadjuvant, whereas you didn't in any of the others? And then the other question separately is, you've talked about robotic versus open versus laparoscopic and made different decisions along the way. Maybe there'd be just a primer as to what those are and why you'd use them.
So with regards to the neoadjuvant therapy, I would say that neoadjuvant therapy in 2013 is still the subject of a clinical trial. It is not the standard of care. But in that other case that I showed, the 50-year-old that received pazopanib, his choices were nephrectomy, dialysis versus, hey, let's try this and see if it works kind of thing. So he was sort of between a rock and a hard place, but it was by no means the standard of care, and that's the way he was informed, told that this is not the standard of care, that this tumor could actually grow while on therapy, but that in my hands at least, I felt that he was almost certainly likely to end up with a nephrectomy and end up on dialysis. And, you know, with that informed consent, he decided to try the drug. But it's definitely not the standard of care. And then, let's see, Dr. Mateen, perhaps you'd like to discuss the differences or why we're choosing robot for this and lap for that and open for this?
Okay, so to try to keep this short, open has been around the longest, right? And that's what we have the most amount of data with, and that's probably the one procedure that you could translate in Houston, Chicago. I don't know why I'm picking on Sri Lanka today. It's Saturday morning, I don't know. But in other words, it's well accepted pretty much anywhere. Laparoscopic procedures were introduced in the 90s, weren't really accepted until early part of the century, but a little bit more difficult for people to pick up on. It just requires a little bit of a different skill set. And then with robotic technology coming into play, that basically allows surgeons to do laparoscopic surgery, but it's done without having to relearn a whole new skill set. So it's still laparoscopic when we do it robotically. It's just that it makes it easier for the surgeon to do. Now, there's a lot of other details I'm kind of leaving out. Bottom line really is it comes down to the comfort, the experience of the surgeon, the training, and their comfort level with what's being presented in front of them. So I don't know if that helps answer your question, but it's not written in a book as to what you should do when, because it's an continuously evolving area with sort of these technologies that are coming out, and then the exposure that urologists have to them as they're in training or in practice.
So I'll just add to that the reason to push less invasive approaches is the recovery. I don't know if you want to say anything
Please,
about it.
yeah.
I think patients that have laparoscopic surgery recover much faster and more quickly than open surgery.
Question?
How you doing? In our case, our doctor doesn't seem to be real concerned with my wife's kidney. She's in stage 4. And is that because it's already left the kidney and gone to different parts of the body, or?
Well, we're going to talk more about that in the afternoon session with metastatic disease, but in general, we use selection criteria that have been published in the literature, some by us, some by others, to select patients for surgery. Not all patients who present with metastatic disease and their kidney in place are good candidates for surgery, and in fact, in many cases, the surgery can be quite detrimental, and it just depends upon certain selection criteria, such as, in general, patients should have clear cell histology, they should have a good performance status, absence of brain, liver, and bone metastases. Those are criteria that we would use to better select patients for surgery. But our experience has been, like, for instance, if a patient has liver metastases and you take them to surgery to take out their kidney, the overwhelming majority of those patients will be dead in 6 months. And it's directly related to the surgery itself because of the debilitating effects of the surgery and the ability of their metastatic disease to sort of take off after surgery. So we use very strict criteria to select patients for surgery. All right, you guys want to do one more case? Why not? Okay. 58-year-old white female, history of melanoma, incidental renal mass, identified on staging evaluation, history of hypertension, hepatitis B, had a cholecystectomy and hysterectomy, and a CT chest was performed, which was negative. It's too bad Chapin left. This is his case. Here's the mass. Dr. Delacroix?
That is an atypical appearing mass in the left kidney. You can see that it looks different than a lot of the other masses that we've seen today. It's not round. It almost looks like you've poured water into the kidney, and it's just sitting there. You see it? Yeah. So on this, I would definitely do a biopsy to help guide what I was going to do. So my first step, because I think it's atypical, is I would biopsy this mass.
Dr. Karam, what are your thoughts?
I agree with Dr. Delacroix 100%. I would do a biopsy. This does not look like a regular, so to speak, kidney cancer.
Dr. Mateen?
I think it's fine. She has no disease elsewhere, right?
Correct.
Yeah, so the concern is maybe that it's the melanoma, and melanoma can do this. I guess I would talk to the person who treated her for it to see that if it was melanoma, if it would make a difference or not, because typically those are managed by surgery anyway, unless they're metastatic. So, I would consider maybe just doing the ultimate biopsy and putting that in a bucket.
Yeah, actually, I agree with you. Because if she has no other evidence of metastatic disease, regardless of what this is, melanoma or renal cell carcinoma, the primary treatment would be surgery.
But just like Dr. Mateen mentioned, the key is to talk to the melanoma doctor, not just to take the patient on our own without discussing this with the primary oncologist who treated the patient for melanoma. Sometimes they can use the tumor to make vaccines from it for melanoma, so it's always good to coordinate efforts with our colleagues who treat the main primary disease.
So the patient underwent a biopsy of the renal mass, and it turned out to be clear cell renal cell carcinoma. They underwent a left radical nephrectomy, spared the left adrenal gland. You can see the pathology was T3A, Fuhrman's grade 4. Postoperative recovery is uneventful. She returned 6 weeks post-op with imaging. And now the imaging, and unfortunately these images are not that great, but basically what it shows is she has new tumors present. Here's one very central. New tumors present in the right kidney. This is also thought to be an enhancing mass here, and there's also an enhancing mass associated with this cyst. So 3 different masses that are all intraparenchymal associated with the right kidney, and some very tiny, indeterminate nodules present in the chest. Dr. Mateen, what do you want to do?
I'd call up one of these 2 guys, but only because I think just to have a discussion. The problem with these findings in the lung is that they're, it's this quandary we're in between with CT scans that we see when lesions are that small. They're too small to do anything about. I'm guessing that's about half a centimeter.
Yeah, they're too small to biopsy.
They're too small to biopsy, but there's something there, and patients always want to do something, but there's really nothing you can do except the risk of a needle in the lung. So, basically I would just, short answer is I would probably look at her, do another set of scans in 2 or 3 months. Not 3, probably 2.
What about the lesions in her right kidney?
Yeah, I mean, the problem with that is that if she's developing metastatic disease and we're overly aggressive with those lesions in the kidney, it's what we talked about. God forbid she has a bad complication. Meantime, she's sitting in the ICU or in the rehab facility recovering from those complications, and the metastatic sites are growing and we can't do anything about it. Mm-hmm. So that's where we run the risk of causing harm, which is...
The only challenge is that the radiologist is saying that these lesions appeared in this kidney over the last basically 2 months. So if you wait another 2 months, are you going to have a kidney?
You will have a kidney, and the treatment may be more difficult, and I think it's balancing those different risks. The same could be said about her metastatic disease in terms of things rapidly progressing.
If it's metastatic.
So I think it's difficult to have a pure win-win situation here.
Dr. Crum, what are your thoughts?
I would follow the patient one more time in a few weeks. If the patient has more metastatic disease, then that tells me that we shouldn't really operate on the right kidney at all.
Dr. Delacroix?
I agree. If you had a girentuximab trial, this may be a place where you could utilize it to characterize those lesions in the lung rather than sticking a needle in them.
Would you like to elaborate that for us?
Everyone knows about PET scans. It's advertised. Well, most PET scans are based on something called FDG, which is where we radio label a glucose. There are other ways to do a PET scan that are not FDG, and there's one marker that's specific to clear cell renal cell carcinoma, actually associated with a tumor marker, carbonic anhydrase 9. It's something that's not currently approved in the United States, but it may be something that will allow us in the future to determine if suspicious lesions in the lung or even primary tumors are actually clear cell rather than sticking needles in them. So when we look at these very small these very small lung masses, the interventional radiologists here are good, but those are very, very small to be sticking needles into. So if potentially the girentuximab scan was approved, that may be a role for it. And if it was positive, you know that this patient has metastatic disease, and the patient could go ahead and start systemic therapy. I don't think there'd be any role in treating the primary tumor here. You would just start systemic therapy.
So in the absence of that,
in the absence of that, okay, to throw that in there, I would rescan this patient in 6 to 8 weeks. I would not go, unless you had a clinical trial, I would not do anything else.
Okay, I would agree. And just so you know that girentuximab, it's been made by a company called Wilex, and the FDA has mandated that they have to do another clinical trial before it can get approved, so it's probably many years down the line before we're going to have that. All right, one more case.
So what happened?
Huh?
Update on that patient.
I wish Dr. Chapin were here because he asked me to put that case in. He's currently debating what he's going to do.
What would you do?
I'm sorry?
What would you do?
I told him to wait. I said wait 6 to 8 weeks and get another scan, and if those nodules in the lung are bigger, you have your answer, and you haven't, because I don't think he can do a partial nephrectomy on that right side. I think she would render the patient ineffort.
So let's say in 6 to 8 weeks, the lung nodules have not increased. They're the same.
Then I'd take a look at the right kidney. If the right kidney hasn't changed, then I'd say, well, let's wait another couple months. I think the only reason to operate on that right kidney is to cure. And if you can't cure her, then you have not done her any favors.
Isn't your suspicion high that what this lady has is, or I forgot if it's a female or...
Female.
She has metastasis to the kidney, to the right kidney, with 3 lesions.
They could be
suspicious lesions in the lungs.
It could be Mets or it could be multifocal disease. I mean, I don't think we can make that determination. I'm not sure it's, to be candid, I don't think it's relevant whether those are Mets or primary tumors. The fact is that they're there. And the real issue is, does she have metastatic disease elsewhere? If she has metastatic disease elsewhere, then operating on that kidney is not going to be helpful, and in fact might likely be harmful by rendering her dialysis dependent.
No, what I'm thinking, my alternative, is, if I may provide an alternative view, is that what she has is metastatic disease. So, if you obviously have to decide, are you going to ever treat the patient before she develops symptoms, or obviously disease is really progressive, or are you going to initiate therapy earlier? So, you can make the case that she should not have surgery, even if those things in the lungs are staying the same, because she has 3 lesions in the right kidney. These are metastases, and therefore she is not going to be.
So would you treat her with the information we have?
I would treat her. I mean, that's an alternative.
Michael, would you?
I probably wouldn't treat her. I'd probably watch for a little while, since we don't know what the.
Would you do a biopsy to prove recurrence?
Suppose she came back and the nodules in the lung stayed the same, but the nodules or the tumors in the kidney increased. What would you do? Dr. Delacour.
Why did Chapin leave? He could get it first. That'd be very difficult. I think I'd try to treat it with systemic. Refer to my colleagues for systemic treatment, because I still think. I mean, looking at the CT scan of the chest, even if those pulmonary mets or pulmonary lesions don't show any growth in 6 weeks, and the primary tumor or the tumor in the right kidney shows a small increase, I would still either watch her or send her down to medical oncology, because I think I'm pretty sure that those are going to be metastasis in the lung.
I would get a biopsy because she has a history of melanoma. We have to make sure before we start systemic therapy to know what we're dealing with.
Biopsy of?
The right, one of those 3 lesions in the right kidney, because the lungs nodules are too small to biopsy to give you a yield. And again, if she didn't have melanoma, I would say, well, there is overwhelming evidence that or probability that this is going to be a renal cell. But with the history of melanoma, you want to make sure you're treating the right tumor. So I would get a biopsy. If it's melanoma, then she will be obviously sent to the melanoma people to treat her. And if it is RCC, I would treat her with systemic therapy.
So I know a little bit more. Brian had actually asked me to look at her kidney and see if we can ablate all those 3 lesions in the kidney. And I think it's doable, but I was worried about the extent of one of the larger tumors, the larger of the 3 extended behind one of the cysts. So that's why we went for the biopsy. And the biopsy was actually RCC, grade 4, nuclear grade 4. The question is, should we do an ablation? And technically feasible, challenging in a solitary kidney, but we haven't reached an agreement yet.
Yeah, I think he's going to watch her because with the nodules those nodules in the lung look really suspicious to me. All right, one more quick case. Don't be so verbose. Just give me an answer, okay? 67-year-old presents with microscopic hematuria, good performance status, CT chest, bone scan negative, no urologic complaints, past medical history is unremarkable. And again, you can see here this large tumor involving the posterior aspect of the left kidney. Here's the renal vein coming into the kidney right there. Here's the renal artery going into the kidney right there. And you can see there's this large tumor involving the posterior aspect. All right. I know what you can do. I know what you might do. I want to know what you will do. Okay? One answer.
Partial nephrectomy.
Okay?
What's going on with the right liver?
Nothing.
Okay, partial nephrectomy.
Hemangioma.
Partial nephrectomy.
Okay.
I'll vote for partial.
All right, Dr. Mateen.
Yeah.
Dr. Arar, can you ablate that thing?
No ablation.
Dr. Tanier, you get to be a surgeon?
For the day, partial nephrectomy.
Okay. How would you do it? Would you do it robotically or open?
Open flank incision.
Open flank incision.
Michael, you don't have to answer if you don't want to. Dr. Mateen?
Yeah, actually, I would not do a flank with this because you don't have that much space during a flank. And for this, you really want to be able to kind of rotate the kidney and get it off of all those blood vessels first and blah, 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 blah. So some technical things. I actually would consider doing this robotically. A lot of it just lies in the strategy of getting it off of the blood vessels before you do anything else. But whatever, robot open.
All right, well, again, this patient elected to participate in our neoadjuvant axitinib trial, got 3 months of axitinib, dose escalation to 10 milligrams BID, and here's the follow-up films. And you can see there's dramatic regression of that tumor. And although I agree with all of you that I would have done a partial nephrectomy, I think this was destined to be a much easier partial nephrectomy based on the response of the primary tumor to the axitinib. And the patient did undergo a left partial nephrectomy, and you can see that it was T1A, Berman grade 2, confined to the kidney. All right. I think you guys have earned your lunch. So let's go ahead and break for lunch, and then I guess we're going to reconvene at 1:10 p.m. with Dr. Tanier running the show. And again, there are those 2 breakout sessions, one for patients, one for caregivers. If you're interested, Carol can direct you. Just grab your lunch and head over to the respective place, okay? And we'll see you at 1:10.